Welcome everyone. Good evening everyone. Wonderful to have all of you on the national panel for Bangladesh, and it's wonderful to have all of you. Um, with this, I'll again introduce you later, but let the formal introductions be done by our official team from Global Health Forum. Thank you.
Thank you. So, good evening, good afternoon, and good morning to everyone. A very warm welcome to session 10 of the Global Advanced Certification Program on Strategic Research Collaboration and Communication for Emerging Researchers and the International Workshop Series, proudly organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, the Global Health Forum, World AIDS Forum, the Global Brain and Mental Health Forum, in collaboration with local delivery partners, Bangladesh Institute of Innovative Health Research. Today marks session 10 of our international workshop and panel discussion series, which features eminent speakers from around the world each weekend. So far, we have had a group of eminent and world renowned speakers from top academic institutions and top global institutions in Africa, Asia, and the Pacific, Australia, India, Malaysia, Singapore, the UK, and the USA. Today, back-to-back national panel discussions are a highlight in our calendar. We gather leading minds from Bangladesh and Nepal to reflect on the present and future of health systems, equity, leadership, and the collective pursuit of the SDG Agenda 2030. These discussions aim to unpack the real-world challenges and showcase the pathways toward transformation. Our goal, One South Asia, is a part of our long-standing vision, One World, One World. And this Global Health and Development Dialogue series is symbolic manifestation of our strong commitment. Once again, we are joined by our respected moderator and host, Professor Maheswar Satpathy, CEO and founder of Global Alt and director at COE ECC PHP, who will guide us through these impactful discussions. The lead organizer of this program, the Global Consortium of Global Health Actors, Leaders, and Thinkers, operates under the Global Health Leadership by Global South Initiative, a flagship program of the Global Health Forum since January 2025. The Global Consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systemic change in health. As of today, the Global Consortium is the largest dedicated professional consortium of global health, with more than 2,000 leaders from 170 plus countries who have applied to be members through a rigorous process of member selection and full documentation of members' credentials. Our vision is reimagining global health leadership by the Global South, decolonizing global health. We are the Global Alternative. The Global Health Forum, elevating voices, reimagining global health, building equitable futures for all. Since 2018, the Global Health Forum is a dynamic international platform committed to transforming global health through inclusive dialogue, critical research, and ethical collaboration. As the parent institution contributing to the Global Consortium of Global Health ALT, GHF serves as a bridge between academia, policy, practice, and communities, especially those from low and middle income countries and underrepresented regions. GHF envisions a future through where global health is decolonized, democratic, and driven by the lived experiences of those at the margins. We create space for cross-disciplinary exchange and nurture the next generation of global health leaders through strategic training programs, public health forums, and capacity building initiatives that cuts across the geographic borders, cultural and social milieu, and disciplinary boundaries. World AIDS Forum since 2011, a high-level global forum to network and collaborate with all stakeholders and communities on infectious disease, HIV and AIDS, BBVs, and STIs, with the aim to unite the world to inform debate, discuss, and act. Instrumental in conducting several hundred programs by leading and collaboration with program partners from all over the world. The Global Brain and Mental Health Forum Reimagining Mental Health Leadership for a Resilient and Equitable World since 2020. GBMHF is a collaborative interdisciplinary platform dedicated to advancing brain health and mental well-being through research, policy advocacy, and international knowledge exchange, founded as part of the broader vision of the Global Health Forum and to complement the mission and objectives of the Global Auth. GBMHF aims to unite researchers, practitioners, policymakers, and people with mental issues, as well as the lived experience advocates across the globe, particularly from the global south. We focus on building capacity in neuropsychiatric research, destigmatizing mental illness, and promoting culturally competent mental health systems that are equitable, accessible, and sustainable for all. Through academic programs, high-level dialogues, and grassroots initiatives, the forum champions a holistic, intersectional, and inclusive approach to mental health. Bangladesh Institute of Innovative Health Research is a non-profit research organization led by students. It works to encourage research among undergrad and graduate students and young novice researchers since 2023. BIHR has been active in research and has regularly organized training sessions, workshops, and seminars to help build research skills. The team includes around 40 students, research assistants, and more than 10 members in core managerial roles. BIHR is committed to supporting the next generation of researchers and helping improve public health in Bangladesh. Some ground rules for our session participants. Please be remained muted during the session unless you are invited to talk. And if you have any questions or any reflections of the session, you can put into our Q&A so that our panelist and the chair and the moderator can pick up and express to our esteemed panelist. Attendance will be tracked from start to end, and an additional attendance form will be shared during any time in the session. So please be attentive so that you don't miss the attendance form and maintain a respectful and inclusive environment throughout. Chat box will be monitored regularly. Any unnecessary, repetitive, disrespectful, unprofessional, and hateful comment in the chat box or Q&A targeted towards anyone will be deleted and such persons will be removed from the session. So we can move into our first panel, reimagining a healthier and sustainable future for all, health systems strengthening and transformation for SDG Agenda 2030 attainment in Bangladesh. We are honored to welcome an esteemed panel of scholars, policymakers, and health leaders shaping Bangladesh's health systems. Panelists are Professor Dr. Abu Jamil Faisal, chair of this session, Professor Dr. Kausar Afsana, Dr. Muhammad Mushtaq Hussain, Professor Dr. Shahnaz Choudhury, Professor Dr. Helaluddin Ahmed, Munaimul Islam Seeger, Dr. Hussein Alami, hosted and moderated by Professor Maheswar Satpathy, who is a world-renowned leader in One Health, global health, planetary health, and brain and mental health. He is a much sought-after expert in epidemiology, health emergencies, and implementation science, and health innovation using the power of emerging and futuristic technologies such as AI, ML, LLM, and generative AI, and geospatial information system science and technologies, and remote sensing. He builds on his core areas of expertise in cognitive and computational neuroscience, psychology, and global health to benefit humanity. His sustained engagement with UN Sustainable Development Goals and ethics in the broader area of public policy has led to holistic societal transformations in various LMICs. Professor Satpathy has a humble H index of 79 and cumulative citations over 157,000 plus. He has published extensively 285 plus peer-reviewed scientific articles and book chapters in journals of global repute, notably in Nature, Science, The Lancet, NEJM, JAMA, and etc., and has offered keynotes and invited talks at more than 200 top international conferences and global congresses in the past 20 years. He has an impressive all-metric score of 68,255, exemplifying the large-scale social impact driven by their work. Professor Satpathy is currently a research fellow at the Institute for Global Health and UCL Global Business School for Health of University College London, UK. and is also a substantive faculty member, professor at Utkal University, Bhubaneswar, India. He is the director and lead of the Center of Excellence in Environment, Climate Change, and Public Health and Policy, a joint initiative of the Government of India and Odisha since 2013. In the past, he has occupied prestigious positions as research scientist at UNSW Sydney, AIMS New Delhi, and consultant clinical psychology and assistant professor at Army Hospital RNR, New Delhi. He has held visiting researcherships fellowships at the University of Oxford and Columbia University in the city of New York. He was a global health consultant, part-time Dalai Lama School of Public Health, University of Toronto between 2020 to 2023. Professor Satpathy is an established scholar engaged with planetary health and well-being, global health, mental health, transdisciplinary gender and sexuality studies, and critical development studies focused on sexual and reproductive health and rights, and politics and ethics of social justice, and aim to nurture peace and harmony in the world. Some of his concurrent research themes of interest cut across health, data, technology development, and policy and law. These disparate clusters do interact and inform each other as they have constantly shaped his career as he has evolved over the years. He is interested in artificial intelligence, ML, and DL, cognitive neuroscience, ergometrics, and their diverse applications in everyday life. He has been engaged in digital health projects since 2005, since their most archaic forms of M-health and telehealth operations, and have played an instrumental role in the application of principles and insights from cognitive sciences as well as expertise in the community development and mobilization in India, and has been recognized for the same by the prestigious forums or institutions such as University of Oxford. He has a successful track record of over 20 years in designing, delivering, and evaluating global and national public health programs. His multifaceted engagements in Asia Pacific, Africa, and Europe, and clinical practice in India have contributed to my well-grounded perspective and expertise. His strong diplomatic skills and proven track record in developing strategic partnerships have helped form vital global collaborations, enriching public health and mental health policies and initiatives. His multidisciplinary approach, integrating development policy with global health, has empowered teams to translate complex research into social impacts in LMICs. We now invite Professor Satpathy to introduce our panelists and guide us through this important discussion on the present and future of Bangladesh's health systems. Thank you very much.
Okay, thank you, Faisal, for the long but generous intro. It's all wonderful experience to have all of you, the country's eminent scientists, policymakers, and the top scholars from Bangladesh, as well as Nepal, those who are attending and listening to us. So we shall start now. So it is my utmost pleasure as well as honor to introduce Professor Abu Jamil Faisal, Chair of the session for National Panel Session for Bangladesh. So Professor Abu Jamil Faisal is a public health advisor, Ministry of Health and Family Welfare, Bangladesh. Dr. Abu Jamil Faisal is a renowned public health expert and an expert in reproductive and sexual health of Bangladesh. Dr. Abu Jamil Faisal completed his medical graduate MBBS with a master's in public health from the USA and a diploma in personal management from Dhaka University. He has 43 plus years of diverse experience in SRHR, women and maternal health, family planning, and contraceptive use, and infectious diseases like TB and COVID-19. Dr. Faisal also works since 2004 as an adjunct faculty of the Population Sciences Department of Dhaka University and the MPH program of the State University of Bangladesh, SUB. Since 28 March 2020, he has been appointed as Public Health Expert Advisor by Ministry of Health and Family Welfare, assigned to Sylhet Division on COVID-19. This includes 29 years in strategic program planning, management, and policy making. He is currently a member of the National Population Council, headed by the Prime Minister, and 3 national-level technical committees constituted by Ministry of Health and Family Welfare, including the CSO focal person of FP 2030 in Bangladesh, he has been inducted into the Technical Committee for developing the country's commitments for FP 2030. The country representative of Engender Health Bangladesh for 23 years, he steered and managed multi-donor funded programs in Bangladesh. Dr. Faisal is a public health physician with more than 33 years of diverse experience in family planning, reproductive health, essential service package delivery program, and improving quality services in Bangladesh. This includes 9 years of working as a clinical service provider and trainer, and 5 years of working on clinical trial and introduction of new AP methods in the national program. He works to improve the quality of and access to clinical contraception, emergency obstetric care, maternal health, PSC, with a particular attention to the transfer of skills and technology to the counterparts. He is also a guest lecturer at Department of Population Sciences, University of Dhaka. He is an adjunct professor and public health advisor, Ministry of Health and Family Welfare, chairman of Health 21, and he is also currently the president-elect of Public Health Association of Bangladesh, the largest and the most apex body as far as public health is concerned in Bangladesh. He is also serving as an advisor on the PARSA social welfare organization. So with this generous introduction, I would like to welcome Professor Abu Jamil Faisal as the chair to chair the session today, and I'll go ahead with introducing because we forgot to share the bios with you, so I have to do the rest of the thing as well, other panelists. So the first panelist in this series is Professor Kausar Afsana. She is professor and lead in research at James P. Grant School of Public Health, BRAC University. Dr. Kausar Afsana is a professor at James P. Grant School of Public Health, BRAC University, Bangladesh. She has served BRAC in Bangladesh for over 26 years and completed her tenure as the director of BRAC Health, Nutrition and Population Program. Dr. Afsana has started to work for BRAC JPSGS since its inception in 2004 and became professor in 2011. She is a medical doctor with an MPH from Harvard University, USA, my alma mater, and PhD from Edith Cowan University, Australia. Professor Kausar Afsana has experience of over 30 years in public health involved in research, implementation, management, and policy influencing at local and global arenas. Her background is quite broad as she was involved in research and evaluation in her early years at BRAC, ranked largest NGO in the world, mostly in monitoring and evaluation of women's health and development, reproductive health and primary health care. Subsequently, she joined in Nutrition and Population Program HNPP as a senior manager to coordinate and implement National Nutrition Program led by the Ministry of Health and Family Welfare Bangladesh government and supported by the World Bank. She conceived, designed, implemented and managed 2 successful large and complex interventions on reproductive, maternal, newborn and child health RMNCH in urban slums and rural districts with a budget of $73 million for 5 years, funded by Gates Foundation and the British, Australian and Dutch governments. Her broader experience in research, implementation and policy advocacy in fact has positioned her in many international and local agencies, including the government of Bangladesh, to influence science policy interfacing at country and global levels in varied areas of health and nutrition. Professor Afsana later became the director leading BRAC HNPP with an annual budget of 30 to 40 million till her tenure completed in 2018. She not only contributed to development intervention but also the humanitarian crisis while Rohingyas arrived in Bangladesh in August 2017. During her journey at BRAC, she was very much involved in advocacy and policy influencing MNCH and nutrition through the PMNCH and the Sun movement at Global Space in Bangladesh. Despite her affiliation with BRAC James P. Grant School of Public Health, BRAC University from its inception, Professor Afsana formally joined at the school in Feb 2019 and has been given the responsibility of leading research and advocacy in crisis and conflict areas as head of humanitarian hub of JPGSPH. Represent BRAC JPGSPH at BRAC and national and global levels, playing a critical role in policy making and planning and providing technical guidance, particularly in sexual, reproductive, maternal, neonatal, child and adolescent health and nutrition and health system strengthening. She has expertise in designing and conducting public health and nutrition research using critical perspectives of social science and medical anthropology. Her strength in employing qualitative methods include ethnography. Over the years, she has gained vast experience in health system strengthening in LMICs. In 2020, Professor Afsana became the vice chair of the science group of the United Nations Food System Summit. She has immense contribution to the science policy interface and dialogues, food system, nutrition, gender, etc. UNFSS 2021 at global, regional and national level. Publications and impact, Dr. Afshana has authored books and widely published papers in journal and books. She has published 2 books, edited 1 book, and widely published 120 papers, 120 plus papers, largely in international peer-reviewed journal. She has a humble H index of 40 and cumulative citations over 20,000, speaking volumes about the impact of her work. She has been awarded many prestigious awards for her academic and professional excellence and contributions to maternal and child health and women's empowerment. The second panelist of today's Bangladesh panel is Dr. Mohammad Mustaq Hussain. Please correct me if my pronunciations are wrong. Dr. Mohammad Mustaq Hussain joined Institute of Epidemiology, Disease Control and Research (IDCR), a senior scientific officer at Department of Medical Social Science in 1993, was head of the department and principal scientific officer from 2011 until 2016. Worked and continues as an independent consultant WHO, FAO, US CDC, World Bank, USAID, CDC Foundation, Global Fund, etc. Now an advisor of IDCR, Dr. Hussain is a member of Executive Committee of Epidemiology of Bangladesh (EPAB). Dr. Hussain is an adjunct faculty of Jahangir University, State University of Bangladesh. He is also a member Board of Advanced Studies, Bangladesh University of Professionals (BUP) and member Population Committee, Ministry of Planning. The third panelist of today, Professor Dr. Sahana Chaudhary. Professor Sahana Chaudhary, MBBS, MPH, MB, GPH, PhD, is Professor and Head of Community Medicine at Bangladesh University of Health Sciences, BUHS, with over 20 years of academic and administrative experience. She serves as Member Secretary of URC and Director of ICP and RC at BUHS. She is Adjunct Faculty at Bangladesh University of Professional BUP, tutor at Maastricht University, Netherlands, and research fellow at INTA International University, Malaysia. She co-chairs the CUGS Competency Subcommittee and is a member of its Academic Partnership Program Initiative APPI of the Consortium of Universities of Global Health CUGH. A WeCope Subcommittee member and former TGHN Oxford team leader, she received the CUGH Dr. Tom Hall Grant and has 41 publications advancing research and global health education. The next panelist is Professor Dr. Hilal Uddin Ahmed. He is a psychiatrist and have graduated in 1999 from Chittagong Medical College and completed MD Psychiatry in 2011 from Bangabandhu Sheikh Mujib Medical University, Dhaka. Received fellowship training on child psychiatry from Fondazione Child, Italy, from where I have also received a certification from World Psychiatric Association, and trained on autism and neurodevelopmental disabilities from South Korea. He also received fellowship Society of Psychiatry and Neurology (JSPN) in 2010, Indo-Global Psychiatric Initiative Fellowship (IGPI) Fellow in 2011, and Y-Mind Fellowship from Sao Paulo, Brazil in 2013. He worked as a temporary advisor at WHO Bangladesh in the field of mental health and substance abuse for a short tenure. Professor Ahmed has 100 plus publications as author and co-author and presented 30 scientific papers in international conferences held in Bangladesh, Argentina, Japan, South Korea, Thailand, Sri Lanka, Canada, UK, India, Brazil, Italy, and Spain. In 2013, he received Professor Hidayatul Medal Award for research contributions and devotion to in psychiatry as a young psychiatrist of Bangladesh. Professor Ahmed has 5 books on mental health published by Prothoma Prakashini, Bangladesh. Currently, he is working as Professor of Child and Adolescent Family Science at Medical College. Then we have the 7th panelist, Monimal Islam Saijir, is a passionate and accomplished public health professional with 12 years of experience in program design, implementation, technical analysis, and knowledge dissemination, demonstrating proven thought leadership. His experience spans health policy and financing, strategic purchasing, water and sanitation, climate change, health system strengthening, and health-seeking behavior. Almost everything that I am truly interested in. His contributions have been recognized through publications in leading peer-reviewed journals in BMC Health Services, BMG Open, Nature. He is also a regular contributor to national newspapers and global platforms, sharing insights as a public health storyteller. Saijia holds 3 master's degrees: anthropology from Rajshahi University, public health James Prick Grant USAID scholar, and urban development policy from Erasmus University, Rotterdam, as a World Bank scholar. He also earned a certificate course in health policy and financing from KIT Royal Tropical Institute, the Netherlands, and professional training from Sweden and Cambodia. Saijir is a committed is a committed and served 24 by 7 basis to advance global health system based in Bangladesh. He envisions becoming a champion for disadvantaged populations and building grassroots leadership capacity. He currently serves as Executive Director of Public Health Foundation Bangladesh. He is also the founder of Health System Matter, a knowledge platform on global health systems, through which I got to know him. Dr. Hussein Al Amin, a good friend of mine and a brother of mine, is a medical doctor and epidemiologist and health informatician. He is the founder and president of Positive Class Foundation, leading global youth empowerment in SDGs 3, 4, 5, 6, and 13 through innovation in public health, digital health, and robotics. As a WHO Fights and clinical manager at Grameen Digital Healthcare, he integrates health technology to improve outcomes. His background includes roles with CRID USA, WSDA New Zealand, UNFPA, and the National Foundation, and all focuses on public health and surveillance system. He lectures in public health and mentors startups in health innovation. He is recognized internationally. He has spoken at Albania and a lead national TV show in Bangladesh promoting youth-led health and tech-based entrepreneurship. So this is a humble introduction of all our eminent. I would to Dr. who is uh, the pattern, the format is very simple. 10 minutes talk to everyone, and it will be initiated by Professor Dr. Abu Jamil Faizi, and also we go to the presentation, which will be moderated. Timer will be put by the organizing team. So if the organizing team is ready, so please put the timer when Professor Abu Jamil Faizi instructs. So yes, to the audience and for very valuable all the minutes. Professor Abjami, you can hear
Pro-
me? Right.
Professor Satpathy, I mean, there have been some intermittent disturbance. I couldn't hear your last piece. Can you say that again?
Okay. Hello. Yes. Hello.
Yes.
Can you hear me? Can you
Now
hear
I
me all
can
right?
hear you. Yes, I can hear you, but
Yes. Yes.
I didn't
Yes.
listen to.
So
Yes, say it again, please.
okay. Yes. What I said is basically, sir, the floor is all yours. You are the chair of the session. So kindly moderate the session. The timer will be on. The organizing team will be cooperating with you by putting the timer. So format is very simple. Every panelist will be allocated 10 minutes as I was communicated. And after the talks are over, so um, you, we shall go ahead with the moderated panel discussion. So that's all. So we shall start now. So you shall be
Okay.
moderating as the panel chair. Thank you.
Okay. Thank you. Thank you very much. Professor Satpathy, you have done a wonderful job in introducing all of us. I mean, all of the panelists here on the Bangladesh side are all the gems in the health sector. Um, I was little unsure that what would be my role, but still, as you said, that I'll be the chairing this session. So in that case, I didn't prepare any slides. So I just thought of mentioning. I will have a very brief, I mean, overview of what I meant and what I want to see that the things are discussed in that way. This is a global health forum. I mean, discussing the health systems of Bangladesh. Very recently, I mean, the Bangladesh health systems, all of the systems involving the health sector has undergone a kind of a review by a panel of experts, by a commission who have proposed a list of recommendations for changing, for strengthening, for certain areas of the health sector, health systems. So that health systems commission report is available, which is a huge one with a lot of recommendations. So I'm sure that all of the panelists, those who would be speaking here, would be taking that into account as well. So that would also be an help to that commission's report in getting it implemented. So that's the first point I thought of mentioning at the very outset. The second thing is that the system, when we talk about health system, we always refer to the six building blocks of WHO, and we keep on talking on each of the blocks, and that is a good way of discussing the health systems. But I think besides these six building blocks, one of the one of the elements which is missing there, and which is cited by the others who discusses the six building block, is the community involvement and engagement. I mean, we may discuss all the six building blocks, and then as already as I mentioned that the health reform commission, they have also reviewed this the entire sector through the lenses of these six building blocks. But I believe that as we discuss the six building blocks, we should keep in mind the community involvement and engagement. And I'm a strong believer that community engagement is not an optional issue. It has to be at the heart of all the discussion whenever we are discussing the health as a health sector, health system as a overall. The third point, which I thought of just alluding here before we listen to all of the panelists. The third one is the ethical application and the ensuring equity. I mean, we always talk about these two little things, ethics and the equity, but it becomes very difficult for us to demonstrate that we are actually performing on an ethical perspective and we are ensuring equity. So in today's discussion, I'm sure that all of the panelists will keep these two soft elements in their mind, and whenever the discussion ensues, we should bring in and the ethical issues and the application of ethics, and then the ensuring equity not for only women but for all the other segments of the population. And the last thing which I wanted to speak out at the very beginning is that the administration, the health systems, I'm talking about the six building blocks and also taking into account the community involvement and engagement, we quite often forget that the implementation of any of the activities of the six building blocks is an administratively being implemented by a set of people, those who are not really the service providers, who are not really the health workforce, who are not really working on health research. They are the public officials, the public, I mean the officials, those who are in the public system, the government system, and they actually allocate resources, they actually allocate all the things that has to be done to keep the health sector moving. But they are very important, the public officials, those who are on top of everything, and that's how they administrate the whole thing. So the administrative system should also be taken into account while we talk about the six building blocks or the community engagement or the ethical issues or the equity. Anything we discuss, we will have to also back in our mind, we will have to also keep a very sharp eye that how these things are being administered, how these beings are managed and administrated by the people, those who are in the public sector, in the public service. So that those four things I thought of mentioning at the very beginning, and I hope we'll be having a very rich discussion on the on the health sector in Bangladesh, in the health reforms, because we are now actually getting engaged. Very soon we will be engaged in health reforms, and so the discussion on the the systems and all of these associated issues, I believe that we will have a very rich discussion. I would stop here, and Professor Satpathy, you would be inviting the first panelist, or should I be
No,
inviting?
sir. You can do it. You're the
Oh,
chair, so
okay.
please, yes.
Okay,
Thank
thank you. Thank you. So I have the pleasure of inviting Professor Dr. Kausar Afsana. I know her very well. So, I mean, she have been introduced by Professor Shatpathy. So nothing more talking about you. Can I request Professor Afsana to go ahead and start your Professor Afsana?
Thank you. Should I share my own presentation or what?
Yes, you can share your
Okay.
presentation.
Let me see where I kept. Hmm.
At the bottom of your screen, you will see a share screen, and I know
Yeah,
that.
I can see. I can see, but I sometimes am lost with my presentation. That's the problem. Just 1 second. Because only one slide is open. Why can't I see it? This is ridiculous. 1 second. Can you see the presentation or what?
No,
No?
not yet. It's
Oh,
coming. Yes, it's
no,
coming.
this is not my presentation.
Oh my
This
God.
is this is not my presentation. What is open here? Oh God. Oh my God. I wanted to see my, this is the problem I'm going to cause all the time. In stop share. Okay. Where is my PowerPoint? That's what I'm looking for. Documents.
you. Do you need any assistance in this
Yeah,
process?
because I send my presentation to your colleagues and I thought that they will be the one who will be showing. So, but can I send it to any of you? Then you can,
It should be available. Either it doesn't need to.
can I share it?
Could you start the presentation maybe?
Now we can see your slide.
It's there, madam.
Can you see my slide?
Yes, Brack
Why can't
James.
I see slide? Okay, it's so funny. Now I can see my slide. Thank you. Thank you so much. Sorry for taking the time.
But the
And
slide, but the
yeah,
slide we are seeing, is this your presentation? Are you
yeah,
sure?
yeah. I'm coming to the presentation. Yeah, this is our slide from the university. Uh, so where is? How can I go to the next one? It's not moving.
Yes, it's moved.
Okay. So this is the title of my presentation: Reproductive Morbidities, Sufferings of Women in Bangladesh. And in this presentation, I would like to speak about some of the global and contextual factors, and also it's not moving. Why it's not moving? Okay. So firstly, I'm going to start with the definition of what reproductive morbidity is. So according to the WHO's definition, reproductive morbidity is a condition or dysfunction of the reproductive tract or any morbidity resulting from reproductive behavior, including pregnancy, abortion, childbirth, or sexual behavior. It encompasses three main categories: obstetric, gynecology, and contraceptive morbidity. Okay, so now the global and national context. Globally, we can see that hundreds and millions of women are suffering from reproductive morbidities, but it remains unnoticed and unrecognized. And commonly, some of the, as I said, that there are three obstetric, gynecologic, and contraceptive morbidity. And for the obstetric morbidities, many of us who are working in maternal health, we know that we have touched some of the areas of obstetric morbidities, but gynecological morbidities are almost remain untouched. So in globally, we have seen that 2,170 million women are suffering from reproductive of gynecological morbidities at this moment in the resource constrained settings. And I've just brought the infertility because I'm working recently in infertility. So 10 million women suffer from infertility globally. But what is happening in Bangladesh? Unfortunately, our data is not very widely available, but reproductive morbidity is also underreported in Bangladesh. And WHO has also an estimation that 1/3 of the women of reproductive age suffer from different gynecological morbidity. And recent studies, which is actually, to me, it's fascinating because I have seen some of our researchers actually done a survey, but it was online, and they found that half of the women of reproductive age, they're suffering from various types of reproductive morbidities. And interestingly, among them, this is an educated group, as it is an online survey, but it is across Bangladesh. And 12,000 new cases, according to our National Strategy for Cervical Cancer Prevention, 12,000 new cases of cervical cancer are occurring in Bangladesh, and 6,000 are dying. And still, and VDHS data is quite old, but 14% ever married girls had sexual and sexually transmitted infections or reproductive tract infections, and 12% of ever unmarried women suffering from infertility. This is kind of some of the data I wanted to say, so we can understand the magnitude and severity of the problems which is happening in the area of reproductive morbidity. The reason is that SDG is not actually touching this area. So you can see that what are the problems is happening at this moment. So let's see the problem, what is happening at the basic our level demand side, socio-cultural and barriers to healthcare and economy. Socio-cultural, we know that the gender norms is actually causing our silence and suffering, especially for women who are suffering from different problems. And when the problems happen, especially infertility and many of our menstrual disorders, women don't talk about it because of the stigma, shame, taboos. And because of the infertility, women has marital breakdown, isolation, and even gender-based violence. I didn't bring the issue, and we know that how it is affecting different group of women. So mental health depression happens, and we can see from the community that women's health is actually not prioritized. So let's see that what is happening in terms of their barriers to healthcare. Of course, the cost. One is cost, one is the knowledge, and then the lack of female healthcare providers in the health facilities, lack of services, distance. Many of the things are affecting women's access to seeking services. And of course, the economic vulnerability, which is very high cost treatment of all those things that I mentioned. So what are the health system challenges? And very nicely, Falsafa mentioned that the reforms is happening at this moment. I hope that we can see in our lifetime, because I have been working over 30 years and Falsafa over 40 years, and we are all stumbling with our health system challenges. But barely we don't see any care in reproductive morbidity and at primary healthcare facilities. Inadequate services in secondary and tertiary healthcare facilities as well. Tertiary private hospitals offer services, but not comprehensive. Lack of trained gynecologists and nurses in this area. We don't have poor data in health MIS, actually showing the reproductive morbidity. But for the family planning, actually, some data are available, and maternal health, there are data available in health MIS, but very limited national studies in different gynecological morbidities and other morbidities. And in Bangladesh, our budgetary allocations for health is very low. And think about that, how much is allocated for reproductive health morbidity. So what are the gaps in policy and practice? Bangladesh has actually good policy guidelines, programs for maternal health, family planning, cervical cancer, STI, RTI, and so on. But we can see that there is a very weak integration of this reproductive morbidity in primary care, and not to talk about the community. So, and secondly, that even if you have many guidelines developed, but some of the guidelines are still not developed. So there are lack of standard protocols for screening and treatment, and there is also inadequate utilization of the standard protocols by our medical professional or gynecologists, and nurses are not even in the scenario. And which is very important, that we have seen that there are examples in Bangladesh that how digitized systems are being used for small interventions. But I don't want to bring all those examples. But in I mean, in terms of our policy, we don't see that there is reproductive morbidity care if we have any inclusion of digitized healthcare provision. So these are all important issues. And as I mentioned about reproductive morbidity data, not collected systematically, or not even reflected in health MIS. These are important issues. And no national surveys conducted on reproductive morbidity as a whole. And adolescent reproductive morbidity is largely unaddressed. So these are some of the gaps in our policy and practice. So my last slide is actually the concluding remarks. So I feel that, we need to have a very systematic way of evidence generation to understand what is going on in this area of reproductive morbidity, and including our strengthening our health MIS. This is very important. And reproductive morbidity care for any care, as Faisal Bhai already mentioned, and the organization I came from is BRAC. We always believe in a community program. So all the health care, especially the reproductive morbidity care, should be connected with our community and primary health care. And more important is that time has come to develop a comprehensive reproductive morbidity care across health facilities and also community. And for that, we need commitment. And I can see that the commitment is coming from the government, but enforcement is more important. And ensuring health financing, which is really, really poor in this country. And I hope that the government could show that there is also healthcare financing for reproductive morbidity. And less attention to women's health, not only in Bangladesh, it's a global problem. So globally, you can see all the rich countries, they don't have not much attention to women's health. So this is a very neglected issue. So to improve women's health, I think we need to have care. That means love, passion, empathy, investment, and comprehensiveness is required for health system to social positioning of women for reducing reproductive morbidities. And also just Faisal Bhai mentions about the ethics issues. And I believe that equity is an important issue, social justice is an important issue, and ethics has to be practiced in the area of reproductive morbidities. So I'll stop here. Thank you so much for giving me the opportunity.
Thank you, Professor Afsana. It's you have touched upon a very subject which needs a lot of attention. We always in the SDG there is no indicator on reproductive morbidity. It's all about the mortalities and the associated ones. We are getting some questions, so Professor Satpathy, would we be taking the questions after all the panelists they speak?
We'll take a few questions at the end, but not right now. We'll go straight to the question, to the next panelist.
Okay, so we'll go on to the next panelist, Dr. Mustaq Hussain. Mustaq Bhai, we always call him as a Bhai. He's a very senior public health practitioner in the country. So Mustaq Bhai, the floor is yours. You are still muted.
Thank you, Faisal Bhai, Professor Satpathy, and other dignitaries. I will present, hopefully within time limit, Professor Afsana Kausar presented a very comprehensive one. I hope I'll be a little, I will mostly work on SDG and how primary healthcare should be given priority as per recommendation from our Health Reform Commission. Let me share my slides. You can see my slides.
Yes.
Okay. Reimagining the healthier and sustainable future for all, health systems strengthening and transformation for SDGs in the 2030 attainment in Bangladesh. This is the topic of our webinar. I will try to focus on primary healthcare, but I am planning to show you the progress Bangladesh, how Bangladesh is progressing towards achieving sustainable development goal. And changing the slide. Can you see my change slide?
Yes.
Yeah, that's okay. I'm saying now with sometime the changing of slide are not seen in the other side. You can see the Sustainable Development Goal 3, health and well-being, and target 1 is for maternal mortality. This indicator is maternal mortality ratio. You can see it is slowly going down. Our target by 2030 is to achieve the number of 70 per 100,000 live birth. It is in the red, but in 2023, we are just below 150. It might be 100 something plus 2023. Our target is on 2025, that this is year, 100, 100 number of maternal mortality per 1 lakh lifetime. I think if we do not work dramatically, that may not be possible. We cannot jump down from 2023 figure to 2025. I am showing you another indicator, under 5 mortality rate. Under 5 mortality, we are progressing in a right direction, but maybe due to COVID or other cause. From 2021, you can see the under 5 mortality is going up. But we have to at least come down to the level of 2021. That is the figure of 2021, maybe pre-COVID, though COVID struck us in 2020. But it is going higher. It is more than 30 per 1,000 live birth. We should have 25 under 5 mortality per 1,000 live birth. The tuberculosis incidence. I am seeing it is flat. In 2015, a prevalence survey was conducted by IDCR on behalf of the government and DGISS with technical support from WHO. It was something like 2025 per lakh, the TB incidence. But more or less it becomes the same. But according to end TB target, which is supported by SDG target, it should go down below 50. We have to just jump from the side of the ship into the sea if we wish to achieve our target. It is not very encouraging. The TB program is, they are trying to put emphasis on detection of TB. Unless we can detect TB, we cannot reduce the incidence of TB. This is the mortality rate attributed to NCDs, non-communicable disease, cardiovascular disease, cancer, diabetes, or chronic respiratory disease. It is going up day by day. You can see from the figure. It's from 2018, the measurement is being done by statistical and methodological method. 2021 up from 2018, then 2022 up. In 2023, slightly going down, but our target, you can see the red one, 2025, it should be less. On 10 and 2030, it should be just about 5.1 or 2. But still, we have to do a lot to improve the situation. I have sources the indicator for our universal health coverage. There are many indicators. I have just taken one indicator. In the HDG tracker, other statistical information is lacking. Health worker density, it has going up very slowly. In 2023, you are see that it is just about something like 12. But it should be in the red line, because it is faint red. It should be 45 according to our the target set by World Health Organization and SDG UN. But for Bangladesh, this target is unique for Bangladesh, but we have to jump a lot to achieve the target from 2023 to 2025. We are lagging behind. And I have listened, Faisal Bhai can correct me. For achieving universal health coverage, government is taking time, not 2030. It was 2032 according to a financial year, but it is now the goal post is shifted further, 2035. I don't know how we can achieve this. But now it is some of the indicators I have shown you. If we can establish primary healthcare based health system as recommended by our Health Reform Commission, some of the element of primary healthcare service is exist for reducing maternal mortality ratio and reducing infant mortality and under 5 mortality. But some degree of achievement we can see for infant mortality and to some extent the under 5 mortality, but for maternal mortality, we are very behind. Primary healthcare and field workers, they are working very much, but we are seeing that every part of our rural center and almost nothing for the urban center, they exist for primary healthcare service for reducing maternal mortality. So this Health Reform Commission, and also before the Health Reform Commission, the public health practitioners and the health rights organizations, they are shouting for introducing urban primary healthcare centers. Till now, I do not know how the progress has been made. The stalled 5th health sector program, they also recommended, they also plan to start urban primary healthcare center. We are waiting to see that. If we cannot start urban primary healthcare services, not only centers, and door-to-door services by healthcare workers and nutrition workers, we cannot improve much. Almost 30% of the population, they are now living in urban area. How can we achieve our targets without addressing these things? Tuberculosis, a very good program is running for controlling tuberculosis. But still, we have to find out why the graph is flat. It is not coming down. I am not so much conversant with the TV program. So if some other people where they can question and answer themselves, how we can bring down the incidence rate. And the NCD, yes, a lot of emphasis is going down. In Bangladesh, the incidence of infectious disease is coming down, but the public health emergency is knocking every time, not only Bangladesh, other countries also is afraid of the infectious disease outbreak, like now resurgence of COVID, dengue, but the non-communicable disease, it cannot be addressed without the prevention of the risk factors that may cause to the rising of communicable diseases, non-communicable diseases. And this is a comprehensive approach of health, all-out health, the health not only for health ministry, they should involve the multi-ministry method. And it start from food, physical exercise, healthy lifestyle, and securing the low-income people, lower middle-class people, and income-less people. If we cannot address them, we cannot prevent and we cannot help to achieve the incidence and the prevalence of non-communicable disease going down. And a big part of is a road accident. It is a preventable. How we are watching that every day, people, dozens of people are dying from road accident. So this should be also included in primary healthcare approach. And government have planned. They have formulated a plan that every Upazila health complex should have an NCD corner. They will be given advice, not only medication. They will provide advice. It is good, but that should be extended up to the community clinic level. And as I said before, urban area is totally out of such focus. But I think, see, most of the people in urban area, they are suffering from this non-communicable disease, including road traffic accident. And I can see the health worker distribution, only one indicator for universal health coverage is available in our SDG tracker, sdg.gov.bd. It tracks the progress of SDG, achieving SDG. I hope if we can include primary healthcare, not for distributing medicine and practicing of medical assistant and doctors for this health center, they should concentrate more on prevention of diseases and health promotion. And that can achieve our targeted goals for universal health coverage and as a whole the sustainable development goal, health components. Thank you.
Thank you very much, Dr. Mustaq Hussain. I mean, that was a very good review of the SDG, all the principal and important indicators. Thank you very much, laying down this foundation for our this further discussion on the health systems strengthening and reforming. Can I move on to the next speaker and the next panelist, Dr. Shahnaz Chaudhary? Dr. Shahnaz, Professor Shahnaz Chaudhary, yes,
Yes.
you are muted. No, your slides,
Yeah,
we can see your slide. Yes.
Excuse me.
Okay,
Thank
Dr.
you so much.
Uma, we are going with the Bangladesh panel. So could you please stop sharing your screen so that Professor Sahnaz can present herself?
Yeah, thank you.
Okay, now you can. Thank you.
Okay, so can you see my slide?
Yes.
Yeah. Okay, thank you. Okay, thank you so much, Professor Abu, sir. So both the presentation were more into diving into the statistics and what is really happening in our health service system. So, but in my presentation, I'll be enlightening the health system in Bangladesh. Okay, so this is the demography and health system profile according to 2025. So we have a population around more than 80 million, 180 million. And the life expectancy at birth is about 74 years, and that is 72 for male and 76 for female. And maternal mortality ratio, it is 123 per 1 lakh live births. And infant mortality rate is 16 per 1,000 live birth. And crude death rate is about more or less 5 per 1,000 population, and total fertility rate is 1.94 per children per woman, and doctors per 1,000 population is around 0.53 doctors per 1,000 people, and current health expenditure is about 2.36% GDP, and total hospital is about 5,800 to 6,100. That includes the public and private institute. So here is the structure of health system in Bangladesh. So here we can see that Bangladesh operates a mixed health system comprising of public, private, and NGO sectors. And the Ministry of Health and Family Welfare is the central authority overseeing national healthcare policy and service delivery. So in the public sector, that is run by the government, that is managed by the Ministry of Health, Family Welfare under two divisions, that is Health Service Division, which deals with clinical care and hospital services, and medical education and family welfare division. And the private sector, which is rapidly growing, especially in the urban areas, offers a wide range of services from diagnostic to advanced care. And the NGO sector, which plays a vital role in primary care, especially for underserved and rural population. And as for example, there is BRAC, Mary Stopes Bangladesh, and Grameen Health, and others. Here we can see the diagram relating that how this Ministry of Health and Welfare, which we have two wings, that is Director General of Health Service, Director General of Family Planning, and from Director General Health Service, we have the medical college, specialized hospitals, and district hospitals. And the district hospitals, we have the Upazila Health Complex, union and sub-centers, rural sub-centers, and the community clinic. And from the Director General Family Planning, we have the maternal and child welfare centers, we have the union and health welfare centers, and then community clinic. And okay, so here is the rural to urban service design, which should be, but basically this picture is upside down. That means the primary level, which I'm showing, that is the expanded part for the tertiary level. But according, like just now, like Professor Jamil said, that we are at the verge of strengthening our health system, reforming. So we really want the picture should be this. So that's why I did not bring up the picture that is the upside down, rather showing this is the format that it should be in the health system of Bangladesh. So the primary section is, primary sector level is provided in the community clinic, the Union Health Family Welfare Center, and Upazila Health Complex. And in the Upazila Health Complex, we have 50-bed hospitals, which provide the outpatient department, an emergency maternal lab, and X-ray services. And also the community clinic, they have the preventive basic curative maternal and child healthcare services. And in the secondary level, we have the district hospital, which comprise of 100 to 250 bed facilities with specialized departments. And at the tertiary level, we have the medical colleges and specialized hospitals. The services provided are the very much advanced tertiary care, and teaching and research is going on. Here is the comparative analysis of the Bangladesh health system versus the world standards. That is the health expenditure in Bangladesh according to 2025, that is 2.36%, and the global standard, that is WHO, has targeted that it should be more than 5%. And life expectancy in Bangladesh, it is shown that 74 years, and the global average is targeted, that is more or less 73.4 years. And the maternal mortality ratio is about 123 per 1 lakh live births, and SDG targeted that it should be less than 70 per 1 lakh. Infant mortality rate is 16 per 1,000 live birth, and global average should be, they are targeting that it should be more or less than 26 per 1,000. Total fertility rate is 1.94 children per woman, and global standard is replacement level 2.1. And doctors per 1,000 population is in Bangladesh 0.53. WHO said it should be minimum 1. Nurse midwife ratio is about 0.3 to 0.5, and WHO has set up the standard, it should be more than 2.5 per thousand. Universal Health Coverage Index is about 49, and the global standard is, they say, it should be 100, and the hospital beds per thousand should be, is about 0.8 in Bangladesh, and the global average, they are countering that it should be 2.9. So the Sustainable Development Goal, and we know that the third goal is directly related to our health. So, and the other SDGs is also linked with our health system, that is Sustainable Development 1, that is no poverty, that is high health expenses, which hinders the poverty reduction. Sustainable Development 2, that, excuse me. So Sustainable Development 2, that is the zero hunger, nutrition interventions are vital for child and maternal health. And Sustainable Development 5 is also related to our health system, that is gender equality, maternal health and reproductive rights are essentials for women's empowerment. And Sustainable
Dr.
Development 6.
Shahnaz, can I interrupt? Part of
Yes.
your slides are not visible. A black kind of a bar is there, either at the bottom or on the side. Can you?
I can't. I don't see any bar.
But we are seeing a bar, a black bar, which is kind of
like a block sort of thing comes, like which blocks the entire thing.
This one?
Yeah, that's
It's okay now?
Yeah, now
This
it's
one?
good.
This
Yeah,
one.
yeah, but better. Yeah, thank you.
Okay, thank you so much. Okay, Sustainable Development Goal 6, that is related to clean water and sanitation, that is safe water and sanitation, which directly affects the health outcomes. So the key Bangladesh government initiative supporting Sustainable Development Goal 3, that is the primary healthcare, that is we have community clinic project, and it is about, at this moment it is saying that about more than 13,000 clinics providing free care at the grassroots level. And the maternal and neonatal health, that is the, we have provide initiative regarding maternal health voucher scheme, and that is the cash and service packages for poor pregnant women to reduce the maternal mortality. And regarding expanded program immunization, yes, this initiative has been a successful one, and we can say that the immunization program has reached about 98% to the community level. And so this high child vaccination coverage has led to reducing in infant and under 5 mortality. Regarding family planning services, we have free contraceptive accesses, outreach workers, and reproductive counseling. And NCD management, we also have NCD corners in Upazila Health Complex, and they provide screening, referral, and chronic diseases care integrated into primary facilities. So you can see here the initiative that is ongoing in Bangladesh, and definitely there is some success stories behind this. So the progress and achievements, that is reduction in the maternal and child mortality, that has reduced from 574 in 1990 to 123 per thousand live births in 2020. And the expanded program on immunization and disease control, we have seen the success. And regarding the improved life expectancy, yes, we have seen that in 2000 it was 65, and now in 2025 it is seen that it is 74 years. And universal health coverage, Bangladesh has developed a high healthcare financing strategy, and it's being piloted in the state of piloting. and to reduce the out-pocket payment and financial hardship. And here I would like to say that the out-pocket expenditure in Bangladesh is around 67%. That is huge. So we need to work on these too. So the community-based health services, already I mentioned that it is over 13,000 at the grassroots level. So the challenges is still there and the gaps, so we need to work on it, and maybe during our discussion, we can bring up regarding this matter. That is, the high output pocket expenditure is about 67% of the health expenditure, which directly comes from the household, pushing many into the poverty. And the burden of non-communicable disease, that is more than 70% of the deaths in Bangladesh. And the health system governance and quality care, there is a limited coordination, weak regulations of the private sector, quality issues in service delivery, and the health workers shortage is also being seen in the urban and rural disparities also seen, uneven distributions of doctors and nurses with rural areas underserved. And regarding the pandemic preparedness and response, we have seen that COVID-19 exposed weakness in the emergency preparedness, testing, capacity, and health infrastructure. So the policy recommendation can come up like the increase in government health financing, that is raise the health budget at least 5% of GDP, and expanding of the social protection and strengthening the health workforce. Maybe during our panel discussion, we can come up with more discussion. So I'm going to go a little bit quicker. Scale up of primary health care, reduce financial barriers to care, and tackle the non-communicable disease and mental health, and leveraging the digital health and data systems. And thank you.
Thank you. Thank you very much. Thank you, Professor Shahnaz Chaudhary. And you are almost at the end of your time. So luckily you have completed it. Thank you once again. Can I request the next panelist, Professor Dr. Hilaluddin Ahmed? Professor Hilal, the floor
Yes,
is
sir.
yours.
Thank you, sir. I am audible and my slide is visible, sir.
Yes, yes.
Thank
very
you.
much.
Thank you. Thank you, Honorable Chair, the learned panelists. It is my great pleasure to say a few words among this eminent panel from the Bangladesh and also the participants from throughout the world. And thanks to the organizer to give me the opportunity to say the few words. Regarding this matter, my title of this talk today is The Mental Health in Bangladesh, the Policies, Services and Future Prospects. I'm not going to the clinical perspective, only for the policy, service and the public health perspective of the mental health services in the Bangladesh. So the today's talk contents is the health service system Bangladesh. Already Professor Shahnaz Madam described the Bangladesh health service system thoroughly. I will not go to very broad aspect in the health service system of the Bangladesh. And I just want to focus on the mental health service system in the Bangladesh, the current scenario. What are the service or the academia or the research and the policy and strategy, what are going now? And the policy to action, we have many policy, not only on the mental health. In the all aspect of our health sector, we have the policy, we have the program, we have the strategic plan, but the barrier is our implementations. So we have to make the policy to the action. And what the way forward for that, the future prospects regarding this matter. So first, the health service system, already Madam said our health service system is the government-based, public-private partnership, NGO-based, and the developing partner also support these. That is the pluralistic healthcare systems, the highly decentralized our healthcare system. But the shortage of healthcare providers and logistics, we found we are almost 50% of the WHO target for the doctors, patients ratios. That is, you have seen the Professor Shahnaz Madam said. And the non-communicable disease are the leading cause of death, and the health budget is inadequate and non-equitable distribution. Sometimes the budget is not actually needed, and sometimes there are some lack of budget in some sectors. So it is non-equitable distribution of our health financing, and high out-of-pocket expenditure for the healthcare system. Socioeconomic inequality affects our healthcare, and need to reform health governance system also. And this is, all the primary healthcare, the community clinic, unions of center and Upojala health complex. Upojala mean the sub districts, and the secondary healthcare, the district hospital we have, and the tertiary healthcare, the teaching hospitals, medical colleges, and specialized hospital and institutes. But there are some gap in among these services, especially the aspect of the mental health services. We will go to the health service system. Bangladesh need to reform the health governance system to reduce this gap also. The Professor Faisal Jamil sir already mentioned the present government's Health Reform Commission's recommendations 2025. The recommendations, the primary and the main recommendations, the spine of the recommendation is the primary health care be constitutionally declared a fundamental right and provided free of all charge to all. This is the spine of this recommendation. And other key proposals of this Health Service Reforms Commission, that is the allocate 15% of the national budget to health sector, establish separate Bangladesh Health Service, Bangladesh Health Commission, essential drugs should be free, and update essential drug list every 2 years and prescribe generic name step by step, and launch the unique health ID and smart health card for every citizen, establish National Institute for Women Health especially. That is also another recommendations. And the mental health, the current scenario, the prevalence of mental health among the adult in 18% and among the child is almost 13%. It is the 2019 National Survey report. And the suicide rate, actually no national survey we have found for the suicide rate, but some sporadic and small survey that estimated yearly 10,000 to 14,000 suicide in our country. Against this magnitude of the problem, the professionals are very, very low. Psychiatrists only 400 for 170 million people, and the psychologists are 565, including the clinical psychologist, counseling psychologist, school psychologist, and others. And other professionals, occupational therapies, speech therapists, they are also very dirty in number. And trained doctors, general practitioners, those who are working in the Upojela or sub-district, that is the 7,000. They trained in the mental health 3 to 5 days, trained, organized by the DGHS, WHO, and National Institute of Mental Health. And long-term training also, we have the 85 days training for the district level doctors. The services, we have the 1,200 inpatient bed in government sector for the mental health, in 2 specialist hospital 900 bed, and among other medical colleges, teaching hospital only 300 beds. Total 1,200 inpatient bed we have. But the services are confined only for the major cities and the teaching hospitals and specialist hospital. Primary and secondary healthcare has no formal mental health services in our country organized way. And the policy legislation, we have many policy and legislation actually, but the barrier is the implementation. We have the Mental Health Act, we have the mental health policy, you have the National Mental Health Strategic Plan. All the panel, the act, policy, plan, all we have. We have the NDD, Neurodevelopmental Disability Strategic Plan, Adolescent Health Strategy, Special Initiative for Mental Health. This we all have. Treatment gap is too high. The treatment gap of mental health, 92% found in the last national survey. We have the 92% treatment gap in context of the mental health services. These are the act, policy, and our national mental health strategic plan. Very big volume document. We need to be implement this. The 4 strategic actions of the national mental health strategic plan, it is congruent with the global goals of the WHO and also the SDGs. And the mental health is not only confined with the SDG goal 3, it is also in the part of SDG 8, SDG 10, and also the SDG 11 also. So many SDG point also cross-cutting with the mental health issue. And this is our 4 strategic action plans in our national strategic planning. We have the 4 objectives, 4 plans in our national mental health strategic plan, that is the 2020 to 2030. And the first one is to strengthen effective leadership and governance for mental health and well-being. That is the health service governing system, and especially focus on the mental health governing system we have to develop. And second goal is the sustainable, comprehensive, and integrated responsive mental health and social care service. Mental health is not only the clinical service, it has the social context also. So the mental and social care service are in all level we needed. And third is to implement the strategies for mental health promotion and risk reduction for mental health condition. And fourth one is the strengthen information system, especially the data generation, evidence and research for the mental health. And last, we want to say the way forward for the future prospect. What are the way forward for our future prospect? That is the integration of the mental health services at primary healthcare level. It is very easy to say, but most difficult work to integration in the primary healthcare system, the mental health services, because the root cause is in the our medical education system. In the 5 years medical education system, there is rarely the students or the portion, the stake of the mental health psychiatry is very low. So we have to develop this community-based mental health and psychosocial care we have to develop, and mental health information system and technology-based mental health service we need, because we have the dearth of professionals. So the technology is a key another solution for this service. Suicide prevention by the WHO approach, and deinstitutionalizations of the mental health service, not the asylum era, not the in the very we say that is the mental hospital, but it is the multi-sectoral approach of the mental health service system. Our target, reduce the treatment gap. We have that 92% treatment gap in mental health diseases and conditions. So the main target is our reduce the treatment gap by this manner. And last slide is that how we deinstitutionalizations and the multi-sectoral collaboration for the mental health. This is the within health and beyond health. I just focus the beyond health is more than the health service. In the health, that is the mental health sector, that is the other than mental health sector. In the other than mental health sector, public health physicians, clinicians, health system financing, health governance, all are very much important for this other than mental health within the health system. And among the mental health sector, we need the experts, researcher, and activist advocacy for the mental health promotion and prevention. And beyond health, we need social welfare, education, finance, women, child, sports, youth, religious institutes, and personally live experience. And thank you. This is all of my presentation, and thank you all for patience hearing.
Thank you. Thank you very much, Professor Hilal. You have brought in a different perspective. I mean, mental health, which is almost, I mean, we don't take into account when we discuss all of the WHO building blocks. So you have brought in a new perspective. Thank you very much. Uh, we want to move on to the next panelist, Monamul Islam Caesar. Caesar, are you here? Yes, you are here. So now
Yes, sir.
the floor is yours.
Yeah, thank you very much. Can you see my presentation?
Yes.
Am I audible?
Yes.
That's good. That's good. Now is it full screen, right?
Yes.
Great. Thank you very much for giving me the opportunity to present my thought in this global platform. And I'm really excited to see that still, I think some countries, they have midnight, like Australia and some other parts, but still we have more than 250 participants. So I think it's really inspiring. And first of all, sorry, because I got a bit cold last night. So my voice may be a bit low and upset. Sorry for that. So welcome again. And again, I'm really glad to present this one. So basically, as a lot of things have been covered in my whole presentation and also the discussion. So here I have given the name of the title is Tackling Resource Constraint in Tuberculosis Control, Challenges and the Way Forward. So basically, you know that TB is one of the program that has a lot of impact on the overall health service achievement. So if we want to achieve the SDG, let's see one case which has enormous impact on total health system across the globe, not only in Bangladesh. Okay, so there are two regions. That's why I have selected TB. I will explain it later in the slide. Next slide. So if you see, this is the basically our health sector key achievement. Already some have been covered, so I don't want to repeat due to time issue. But I would just say that there is a family planning achievement, maternal child health, immunization. For example, we have covered based on the data in 2023, 97% national coverage, whereas our neighbor country, even like Pakistan, they have still less than 70%. Afghanistan, they have like around 60%. So those are achievements we have achieved. But if we look last 2 years data, I'm sure the success rate has been a bit reduced. So these are the data from 2023. I don't want to say the reason here now, maybe in challenge part, we can cover that part. And of course, we are very much, like happy that our ORT and community-based care, those have been globally actually recognized as a proven approach. So that is one thing. But today I would like to talk about TB because we have also some success about like the TB. So 2 regions I have selected the TB case. First, I worked in the TB program, though my focus was not TB, but strategic purchasing, health financing, and regulatory issue in last 2.5 years with the government and the donor and also the NGO sector. And second reason is that TB is the only program in Bangladesh that mostly depends on the donor and NGOs in terms of funding and also the implementation. So government has actually a governance, but I am doubt how much governance they have in the TB program. Rather, or like 50 to 20 NGOs, they're basically implementing all the program in the 64 districts. So that's why I have chosen this TB topic. So we understand the dependency and we also understand the challenges ahead in our country. So if we see the achievement of the TB cases, the key achievement is, the treatment success rate. So far, it's like 90%. And we have also the DOTS coverage. So DOTS mean, I'm sure all of you know, but just for your kind information, it's a direct observed therapy. So we have a like national coverage and we integrated with the primary health care through our community health care since 1990. And WHO also appraised this approach and they also recognize this approach. But there's a challenge of that one. I will cover in the challenge part. And if we look at case detection, so it's also achieved around 81%, and where WHO actually, we covered like WHO suggested like at least 80%. So we are in a good position. And most important thing is that like public-private partnership. So we have a robust partnership with NGO or private sector entities to reach unserved area. And there is one beauty of this program that in TB program, there is no overlapping in terms of geography. So for example, if one NGO works in one district, no other NGO actually works in the same service. So that's a good thing. There is no overlapping. I would say this is also systematic achievement of us. So now if we go to the next slide, that is like, the challenges. So I would say that there are a lot of challenges, but I tried to make it, like the program and financial challenges here. So first of all, heavy donor dependence, whatever I said. For example, last year, based on the data and also some verbal, like information from our government official, like the secretary, senior secretary. So far, our donor contribution in our total health sector is like 8 to 10%, between 8 to 10% only, right? Because 20 years back, they contributed like 30%, 25%. So compared to 20 years back, it's actually not much. But if we consider only TB program, then actually it's actually more than 50%. So you understand the dependency of the donor in the TB program. And also the service disruption. So if we look last 1 year, and particularly last 5 months after like stop work by the USAID, I think there is a huge service disruption that we have seen in newspaper and other media. So there is no enough like medicine and a lot of things. Now there is a limited domestic financing. So as I said, that is highly dependent on the donor. So that's why also we know that the catastrophic cost is high. And TB, people actually get the TB service free of cost. So DOTS implementation. Why I think that DOTS implementation is also one of the challenge? Because this is actually door-to-door approach. So when you introduce door-to-door approach and feeding people without whether they have motivation or not to take the treatment, so it's really tough to sustain. But I understand that for 1 to 2 decades it's fine, but we have to come out from this approach. We have to create the demand among the service takers, so the program can run. So as there is a huge shortage of human resource, already some of my previous colleagues actually shared that one. So DOTS can be one a challenge for us. Last is sustainability risks. So what it means, like when donor transited, like you said already transited. So now we are dependent on global fund, but global fund also dependent most of the part of the USAID. But I'm sure that after 2 years, 3 years, or when we actually go from LDC, graduation, then a lot of donors will also decrease the fund. Then what will happen? What will be the sustainability? What the transition plan we have? I'm sure that here there are a lot of policymakers from the government side, private sector. They know better, but as far as I know, that I don't see any that kind of actually transition plan. So now this is the bit solution. So I'm not here like to give the solution, but what I can say based on my experience, based on data, I think these are important. And recently, our government, like the Health Commission report, Reform Commission report, they actually published a report, comprehensive, I think 352 pages report. So that is also eye-opening because they have covered a lot of things, like mobilized domestic resource. They have mentioned that part. Unfortunately, they failed to say how we can actually mobilize this domestic resource. And we have seen that our government yet to start anything so far of the recommendation of the Health Commission report. So that's the challenge. We have been talking about a lot about social health protection, but we don't have that level of scheme, that level of clarity and confidence. That is another issue. Optimized partnership, I think that's important because when you have like a lot of dependence on the NGO, the private sector, it's really important to utilize their potential. Unfortunately, in Bangladesh, within the public procurement system, government cannot take the service from NGO within the government money, but they can only take the service if it comes from the donor funded. So now it's time to change this our regulatory, PPA, Public Procurement Act, Public Procurement Rules. I have seen some changes has been already proposed, but we don't know when it will be published. Without the Parliament, I'm not sure what will be the future of that one also. So the last solution would be the plan for donor transition. But I said gradually donor will be decreased. So I think we should have a roadmap how we can continue our service within our technical and financial ability. I think that's important. So if I go the last slide, I would say that yes, Bangladesh has a lot of success in TB control program. We have collaboration, innovation, community center care, great. But this is the time to transition from dependency to resilience is now. So I would say two things in terms of call to action. First of all, government, they have to prioritize the domestic investment and utilize that, gain technical expertise from NGO. And here governance is key. If they have the governance, I think we can achieve that one. Second, the role of NGO and civil society. NGO played a big role in TB program. They have a lot of innovation, community-based healthcare, so they have a lot of strength. So now they have to also, come out with the innovation, and government with to embrace with the system thinking. Unfortunately, system thinking is totally missing in our ministry because if you want to embrace the complexity, system thinking is really important. What Sir previously said, Helal sir, that we have a multi-sectoral, collaboration. So when you have complexity, multi-sectoral approach, thinking is really important in that case. I see a sound. Okay. So the last one is yes. If we want to achieve the SDG, I'm sure that we are not going to achieve the SDG by 2030. This is very obvious. But if we want to actually achieve our TB target, then I think we can at least near to reach the SDG target. And finally, I would say we can reimagine a future where no one is left behind. However, it depends on governance and political commitment. Thank you very much.
Thank you, Dr. Caesar. I mean, you have brought in another perspective on the TB. I mean, working, and as you have worked on TB, you have explained that how TB we can move further in spite of the fact that donor funding is depleting. We have the last speaker. May I request Dr. Hussein Al Amin?
Yeah, so thank you so much, sir. Yeah. Can I share my screen? Yeah.
Sure.
Okay, thank you. Is it visible?
Yes.
Yeah, thank you. Thank you so much. Basically, I'm a young person, and I believe that young generation can make a lot of impact to fulfill the SDGs agenda. And my things is completely separate to different about the topics. Basically, I have developed an organization named as a Positive Plus Foundation. It's an international organization, and I have a team, and today I would like to share how this team can directly or indirectly involve the community awareness, not only in Bangladesh, but also in the other area by sitting in Bangladesh. So let's start our discussion. So if I would like to share especially in the Bangladesh, strengthening the health systems, already our speakers are doing the current state analysis, already all know that. We already knowing about the key challenges. We know about what will be the strategic proposals. We know how we would like to go for the resilience building. We know how to do the equality and how to sustainability promotion. So this is already discussed. I don't want to share details. Second slide is basically, yeah. So the challenges of the Bangladesh health system performance. I think not only Bangladesh, other than the LMCIs, has a very basic challenges. Number one is the workforce shortage. We don't have the insufficient healthcare staffs. Not only the sufficient, but also the quality healthcare staff is very, less in the LMCI. So workforce stress is a very common things. Second is the out of the pocket cost. The high expenses is always there, and we always need to be, for the donor. When donor will provide us some the money, then we can use this from our side. So this is a common practices in the LMCIC, and Bangladesh is also. Third thing is government. Governments have the insufficiency. We can't deny the corruptions. If maybe we have the 100% people, we have a good heart, but corruption we can't deny. And where there is insufficiency, people are not there, so definitely quality of the healthcare is reduced. So that will be the another problem. Unequal accesses. So equitable distributions is one of the part of the primary healthcare, but unfortunately we don't have the equal access to the people. Not only the people, but also the domain that we need to be focused, right? Finally, the infrastructure deficits. We have a lot of the facilities, but we need to the lot of the facilities and doctor-patient ratio in Bangladesh rather than the other LMCI is also with the same problem. So ultimately, this problem is very obvious. People know about this problem, but this is ultimately the challenges regarding our healthcare system. But how we can solve this? You know about the new Bangladesh 2.0 that we are talking about, the new regulations in Bangladesh, right? So youth exclusion previously in the health policy was the curse. So what we can do, we can make these populations and these young generations to convert into the perfect one, right? We have around 45% of the young populations, and we can't, excluded them from the health policy. So these will be our frontline agents. They can change the behavior, they can change the health literacy, they have the digital healthcare support, they know about the technology. So this amount of the people, if they have get the knowledges and share the knowledges to the community, ultimately this community can be able to change. So that change of the community can ultimately turn our problem into the profit, maybe into the actions, and maybe into the success. So these people's, as what we are working, we call it as a positive virus. So from my Positive Plus Foundations, we make a team, and this team is called the Positive Virus. They are the bridges. So they are taking the knowledges with a lot of the professors, lot of the institutions, lot of the international and national conferences. After that, whatever they have learned, they would like to share to the community and ensure that community people can ultimately do these things. Because if we are able to change ourselves, our family, then community can be changes. So this is a very simple mechanism by which we can easily convert all the problem into the solution. So this is my model, and that I call the 4P model of the positive virus. So the people who believe on the 3 domain, positive personality, positive thinking, positive action, these 3P ultimately converted to the positive virus. And as a positive virus, we are working on the SDG 3, 4, 5, 6, and 13 goal. Whatever we are inputting, we basically focus on the school students, where we convert a school to the health innovation hub. We go there, we have the e-learning platform, we are encouraged there, we are empowered them, and ultimately those people are exponentially distribution of this positivity to their community. They do the community engagement, they change the lifestyle, and ultimately they also be the part of the global policy and intervention. So this is the golden model of the positive virus. And look, this positive virus model is not only in Bangladesh right now. By sitting in Bangladesh, we have deployed in 10 countries around the world. You can't imagine. We have the operation in Liberia, we have the operation in Nigeria, we have operation in the Kenya, Cameroon, and other countries. Even professor also been there. We have a lot of the discussions in India, Pakistan, and other language countries as well. So just an idea, just something using the learning platform, just use the people, use the volunteers and local NGOs. We just turn all the problem into the solutions. And this is our one of the team in the Rangpur. You see the beautiful students who are in a positive hiders. They have the banner of the positive personality, positive thinking, and positive actions. And ultimately, they go to the community and change their community as well. And this is our another team in the Mymensingh. That was the team of the Rangpur. This is the team of the Mymensinghs. They have designed a lot of the ISC materials of the healthcare awareness on the lot of the things, and they ultimately deliver the community. This is our health awareness camp, which just not only focuses the awareness, but also taking the healthcare of our students, our members. And we have some healthcare innovation hub of the school in the Gazipur. So we are piloting all these things. We have another program in the Bijoy International School where we also be piloting there of whatever we are doing. And this is our e-learning platform. I believe this is one of the, the first or second e-learning platform that completely focuses on the SDG. So you look, SDG 3, 4, 5, 6, 10, and this is the online platform so that anybody, any corner of the world, they can take the notes, they can get the information, and that has been designed by the Bangladeshi students and all the Bangladeshi entrepreneurs, and that all the people are working with me. And that is a very big achievement so that we can easily involve around the world, not only the healthcare standing in Bangladesh, but also we can parallel the same kind of the people, same kind of the country around the world. And look, this is our team in the Liberia, the beautiful people in the Liberia, that are Liberia students. By using our e-learning platforms, whatever I am talking, by physically or by the online, we are providing all the information to them. They learn it, they achieve it, and they do to their community and provide that how it can be provided, how it can make an impact. So whatever we do, it's an impact. It's definitely a result. So there will be no documents only. We have the plan, we have the problem, we have the solution, and ultimate solution come into the result and come into the impact. So already we have 500 plus young volunteers around the world. We have done 800 plus healthcare screening. We have 1,500 plus students directly participate in our programs in the online. And you can't imagine, we have only 10 months to build up our organizations. It's not even up 1 year. So within the 10 months, we are crossing the 10 countries. So what we are focusing ultimately our strategy to work on the primary healthcare, human resources build up. Maybe we cannot do the infrastructure by ourselves, but we are using the school as a health innovation hub so that people can get all the things, because we have the leaders, we have a lot of the positive virus in this school so that they can able to award them. For the healthcare financing, already we have the e-learning platform, so we have the model to get some profit here. We have the governance, we have planned some collaboration with the government. Definitely we have the technology, social determinants, health education, health security, all the things we have already working on. And we believe in the fourth thing that is very important to especially the healthcare focus on the SDG 3, telemedicine and digital health. This is a urgent emergency so that we can use our mobilizations, our people, we can use this our people. Mobile health also the third. Artificial intelligence, we have a artificial intelligence teams so that they can use the innovative approaches around the world, not only Bangladesh. And data analytics is also the great part to transforming our healthcare into the innovation. So the strategy is very finally, we need the combination of the government, civil society organization, and private sector. It's a public-private partnership. But basically from my side, we are synergistic our own people so that they can change their life. Because if we are not changing, government or private sector cannot change ourselves. So our main focus is to be the community people. And finally, we basically, this is our 4 key framework to fulfill our SDG. We are making some key performance indicator, regularly monitoring our health, access, and progress, how we are going through. We have a good data collection and analysis team so that they can make some comparative analysis, because it's very important for the decision making. Accountability measures, we are basically making some effective resource uses and progress of the every school so that we can ensuring really they can be, community engagement has been done. And ultimately sustainable development goals that we believe are not only, the one goal, but also all the goals of the SDG should be fulfilled. And I believe that if we work together, and ultimately we can believe ourselves, we can change the life. So from the Positive Plus Foundations, as a positive virus team, our quote is very simple: let the change begin with me. If I changes into the Bangla, our quote দ্বারা হচ্ছে আমার হাতেই হোক আমাদের পরিবর্তন. So let the change begin with me. Thank you so much everyone for your contributions. Have a nice day.
Thank you. Thank you. Dr. Amin, thank you very much.
Thank you, sir.
Being the last panelist and also the youngest panelist, you made a point. Definitely, you made a point that the youths can change this whole thing. We have gone through each of the panelists. They have spoken about their issues. Now, can I hand over the floor to Professor Satpathy so that you can moderate the discussion. Professor Satpathy.
Okay, it's been wonderful and experience listening to all of you. It's I've learned a lot about Bangladesh today, obviously. So that is one of the best things about this panel. So we'll go straight into panel discussion now. We have a very tight schedule to match up with because the Nepal panel resource persons have already arrived and we can't make them wait for a very long time. So unfortunately, that's what happens on a virtual platform. We go by a few minutes exceeded, then everything gets delayed. So I have a lot of questions for you, everyone. You can take up any question. Anyone wants to respond to it, I'll be just asking straight a question and you can respond to it. Whoever wants to respond is welcome, but in order. So if you want to discuss among each other, like how do you want to respond, then it's okay. Because the questions are, there are 6 blocks altogether, on the basis of which questions are going to be asked. And the first block is, the thematic block is SDGs, equity and resilience. So the first question is, how can Bangladesh accelerate the alignment of its universal health coverage UHC efforts with the broader SDG 2030 agenda, particularly in the face of post-pandemic recovery and climate vulnerability? So anybody, you are free to respond, whoever wants to respond. Professor Abu Jamil, do you want to start, or anybody? Professor Kauser?
Let me start, because this is a very important issue. And not only Bangladesh, many of the countries, we are actually far behind SDG. Say the only one country will be achieving one is SDG. I don't remember now. So think about that. One is SDG achievement, and secondly is the universal health coverage. Universal health coverage itself, for myself, I always believe that, one is health coverage. Secondly is the quality of care issues. And thirdly is that how you can reduce the healthcare expenditure from the out of pocket. This is very important from the USC perspective, and that is not happening in any of the countries. In Bangladesh, out-of-pocket expenditure is increasing day by day. And I'm sure that in India, you are experiencing the same. We are pushing, we have presented mostly our public health sectors, health system, but you can see that how the private sectors are mushrooming in this country. So we need to actually discuss, and we have been discussing, it's not that we are not discussing. And thirdly is the climate change. Climate change is Bangladesh, we always think that, some specific areas are affected by climate change, but actually the whole Bangladesh is affected by climate change. You can see everywhere that what is going on, and I'm sure that India is the same experience, Nepal, Bhutan, we are all suffering from the climate change vulnerability. So what we should be doing, should be sitting. So one is the things that we are working on the climate mitigation. And unfortunately, from the health system, our response is quite slow compared to the agriculture sector, where we need our food, so we actually focused our most attention in the food production, not much in health sector. So the time has come that how we are going to develop a resilient health system. Some of the areas we are working, but in terms of our understanding is also lacking, that what we need to do in the health system, climate vulnerable areas. I'll stop.
Okay.
We have a lot of questions, so I would request every panelist to be very brief, because I'll be actually complementing many questions as we go ahead. I'll be complementing.
Okay.
So there will be many thematic areas which you can touch upon. So let's be very brief because we have 8 panelists, and so I'll be asking each question. Whoever feels comfortable, please respond, and then we'll quickly move to the next question. Yes, Professor Jamil, please.
I see that there are 2 questions for me directly, referred to me. One is that why the medical professionals are not taking up the role of leadership or leading the health sector. That's the
Okay.
first question. And the second question is that when USAID grants have been cut off, what is the plan to continue the tuberculosis program, EPI, maternal and child health program in future? Both of these 2 questions are linked to each other. The first, that medical professionals, it is not true that medical professionals are not coming forward to take up the leadership. They are coming forward, but as I said in my opening remarks, that we will have to be very careful in working with other people, those who are actually managing and administering the whole program. So the medical the personalities, those who are coming up to lead the program, they need to also negotiate with the professionals, the public sector, civil service professionals. That's number one. So the negotiating skills and working with them, that has to be strengthened. When the USAID funding has been cut off, it has to be our own resources that needs to be reallocated for these important programs, the tuberculosis and EPI, maternal health and child health. We need to reallocate our budget. I mean, it's very unfortunate that the budgeting is being done not on the basis of the need, but the budgeting is done on the basis of that what is the requirement of salaries and what is the requirement of vehicles to be purchased or the buildings to be made. So we will have to actually change the modality of our budgeting system. And if we can change the modality, then probably we will be able to reallocate our own resources. And the last thing that we need to keep in mind, that even when we are allocating resources, we have been unable to spend it down properly. Quality spending has been a big issue in the health sector. We have not been able to spend it down properly. And then, as Caesar has mentioned, that corruption is a big issue, misuse, unused, all of those things are there in the system. So then we will have to keep an eye on to all those things. I think I have covered those 2 questions. Thank you. Over to Professor Satpathy.
Yes, we shall not be taking any audience questions now. We will be only focusing on the moderated panel discussion now. There are many questions that we have. We have altogether 25 questions for the entire panel. I've just ended one. So many questions will be complementary. So please bear with me. And please everyone be on mute. Please everyone be on mute. Can everyone be please unmute? Yes, thank you. Okay, we shall go to the next question now. What critical institutional, financial, and governance reforms are needed in Bangladesh health workforce development and retention strategy to close the last mile equity gaps and ensure quality service delivery in hard to reach areas?
Can I take on this question?
Please. Yes, please.
Okay. I mean, the only point that probably has not been discussed that much is that the community engagement. The corruption issue, the governance issue, the leadership issue, all of these issues. If we could have involved the community, and if we have engaged the community, then probably a lot of the issues we would have been able to address and cover. As Dr. Hussein Alamin has said, that the youths, now I believe very strongly that the youths, if they are involved now in the policy making, in the implementation, in the administration, we can take care of all of these issues which you have mentioned? Thank you.
Anybody else wants to respond to that question?
Yeah, I think I would like to respond to this question as well. This is really important. As I also echo with Faisal Bhai, is that community engagement. And Bangladesh, if you see the whole success of Bangladesh is actually the community engagement is one of the major component. And Faisal Bhai didn't speak about the family planning program and how much contribution he has from himself to family planning promotion in Bangladesh. So it's a whole engagement of the community who actually took everything, how to mobilize the community, how the people get involved, and also for decision making. And I remember that all the religious people, that how we bring in Islamic country like Bangladesh, where dominated by Islam, how we actually use religion and bringing example from Indonesia. So these are actually part of the community engagement. So the engaging community is a critical part. And now, the day by day, the sophistication of our healthcare system actually, distancing ourselves from the community. And we need to go back, because without community and without community health workers, we have not talked about the community health workforce, the reimagining the healthcare that we have been talking about, that transformation is not going to happen soon. And this is critical. Without them, we may not be able to possible to achieve SDG 2030, forget about that. We may not be able to achieve in 2050. That's what I am thinking. So we need to be very serious.
Yes, Sajia.
Yeah, I just would like to compliment madam. So when you are talking about community engagement, we have to understand one more thing, that our health system mainly focused on rural system, not urban system. It was emphasized on rural system, but if you look the population dynamics now, it's 60-40. So 60 in rural area, 40 almost urban area. But what about the community engagement in urban area, especially city corporation? There is no that kind of community ownership. So that is the challenge. And urban dynamics is really important. So our government need to realize that one. And that's why I'm saying the system thinking is important, innovation is important. The traditional method, the traditional budget like the parts, paid budget, this doesn't work. So we have to have the need-based budget. We have to the new leadership, innovative leadership. Traditional, anything does not work in that sector. So when we are talking about community investment, the most important thing, I think we need to rethink how we can ensure the community investment in urban area. Thank you.
Okay, and then we have Dr. Mohammed Mustaq. Yeah.
Thank you. I cannot show my face because I'm in a car. Anyway, there is a important question that in rural area, doctors are not working and they are reluctant to do work. I think our approach is a wrong approach. Just after passing MBBS from a medical college in urban area, the young doctors mostly are trained in clinical services, but I think they are being thrown into the villages to serve, so that like the military exercise, they should be thrown into a very difficult situation to teach them how they can learn to swim in the rural population. But serving the rural people is not an amateur job. The doctor should be trained in public health before they can be posted at rural area. And after they are passing from MBBS in an urban medical college, they should be posted in that very much medical college or like other hospitals. And in the meantime, they should be trained in public health. It might be a short training or MPH or something that. And the serving in rural area should be treated as a specialized medical care, like a cardiologist or neuroscientist, etc. So serving rural population, we are ignoring the rural people, considering them as only guinea pigs. So we are allowing the young doctors to do whatever they can with the rural people. That cannot serve the purpose. We should change our mind, change our orientation, and serving the rural and urban poor people should be a specialized service and trained in public health. Thank you.
Okay, thank you so much for the wonderful responses, all of you. So I'll go quickly to the next question. Despite significant improvements in maternal and child health indicators, Gender-based health inequities and adolescent health remain under-prioritized. How can the national health strategies become more equity-centered? What are your views on this?
In Bangladesh, we do have a very comprehensive adolescent health strategy. And in our health facilities, we do have also adolescent health corner. But one of the country in the world, I think, the Bangladesh is one of the country that our child marriage is the highest in the world. So think about that, the adolescent girls getting married so early. So that's one of the reasons that why adolescent girls are still behind. And in our data system, in a national data system, we can't even collect many of the information about adolescents' own health problems if they remain unmarried. For married adolescent girls, we can ask some questions. For unmarried, we cannot ask many questions. So there are huge problems in this adolescent space. And we did some research, but I feel that we need to have comprehensive, multidimensional research in the adolescent space to understand better. And not only in adolescent, we always talk about adolescent, but my feeling is that one of the area we are completely missing is that 5 years, from 6 to 10 years, that age group is completely missing. And suddenly, at the age of 10, we start discussing about adolescent. So what about that age group? Because you cannot, in the life course, when the WHO is talking about the life course for our development, how could you actually disaggregate or isolate all those age groups? The windows of opportunities are really important. We know that, for this specific group, we need to invest more. But I think that for our development, we cannot ignore any age group. And the question came in for adolescent, I feel that for each of the developing countries, especially for us, adolescent area needs to be understood better to develop the interventions. And one of our colleagues actually mentioned about systems thinking. So that systems thinking is missing in our understanding of developing the intervention. This is critical to develop an intervention for adolescent.
Definitely. I would be a bit biased now. I will go to Dr. Sahnaz to respond to this question as well, in addition to Dr. Abu Jamil. You have to unmute yourself, Dr. Sahnaz. Yes.
Yes?
Yes. I can hear you.
Yeah. So what was the question? I didn't hear. Break.
Okay. The question was already asked. The question is, despite significant improvements in maternal and child health indicators, gender-based health inequities and adolescent health remain under prioritized. How can the national strategies become more equity-centered?
Oh, okay. So yeah, definitely. Yeah. So Professor Kausar has already mentioned that because the adolescent is being ignored, that part of the service, we must, if we want that equity should be sustained, because they are the future generation. So if we are not equitably giving the services to this part of the population, I don't think that the health system can be a resilient one, and that can have a sustainable development. So definitely looking forward to this the adolescent health incorporation and more sustainable health services providing, definitely. Thank you.
Sure, thank you. Yes, Professor Abu Jamil.
I was thinking that whenever we talk about equity, we need to ensure that the whole of the society should be involved. I mean, addressing adolescent issues, we need to address the issues raised by the parents, by the societal gatekeepers. And so equity can only be addressed if we take into account the whole of the society. Thank you.
Okay, thank you so much. Okay, I'll go to the next questions. I'll ask two questions. I would like you to respond to both of them. First is, how can the academic institutions, NGOs, and civil society be meaningfully integrated into Bangladesh national health policy and planning ecosystem to ensure the bottom-up accountability? And the second question is, in what ways can the South-South cooperation within South Asia contribute to the shared solutions for resilient health systems, and how can Bangladesh take a leadership role in this vision?
Okay, so I will take the first part, that how this education institute can be incorporated. Yes, because I'm an academician, so I think Professor Mustaq already said one of the thing that like, because our health system is structured in such a way that everybody is focused into giving curative health services. But based on the, like Professor Kausar already said, and I also said, that every time we are seeing that the health expenditure, out-pocket expenditure is increasing day by day. So what we can do, we cannot be based on the curative health services anymore. So we need to be focusing on preventive, and how as an academic institute, how we can do that. So that means, like Professor Mustaq already said, that before placing the healthcare service providers into such an arena that they don't even understand what community is, so I can't give the services to them, right? So that means from the academic institute, I think if their policy is that, like in every from outside of Bangladesh, we see that everybody having the MBBS degree, but they have the MPH degree, because that means they have the public health degree, and that's why they understand that prevention is better than cure, right? So in our policy also, it should be mandatory, because after COVID only, I think the health system or the health professional, they had understood that yes, public health is not a degree only, but it has to be into our soul when we are providing the services. So I think from the academic aspect, I think the policy should be there that short training or even having a master degree, public health should be incorporated into our health system. Thank you.
Okay, thank
that
you.
was the first part. Thank you.
Okay. Anyone who wants to respond to the second question, which is a very important
Second part, I would like to respond because I was very much involved in the South-South cooperation. So one of the issues that we want to bring, that history of SARC. We all know that how SARC was formed in 1980s, and SARC was more or less active, and SARC is still working in different countries. But the system, because I was engaged in at some point in my research that with involving SARC, that especially for the sustainability, and but the bureaucratic system makes it, it's so slow in terms of taking decision. That makes the system not very supportive to the countries. And we need to, as we raise these issues, maybe we need to do further research and to understand that why this system is so slow, that is not supporting each partner countries. That's important. And secondly, there are many South-South cooperation, in fact, going on in nutrition, in health, and sexual reproductive health, climate change, but they all work in silo, and that's the problem. So and as we have been talking about SDG, and we are talking about systems thinking, and this siloing approach is not very helpful. And in this forum, we discussed today about that these issues. So maybe we have some responsibility to have a better coordination of the South-South cooperation in terms of helping each other. And South-South is not only South Asia, but also with African countries and also Latin American countries and our many other Asian countries. And there are some countries with so many good experiences that is going to be a learning for us, especially for Bangladesh.
Definitely, agree. Okay, I'll go quickly to the next question. How can we reimagine health system not just as service delivery platforms, but as agents of social transformation and economic empowerment, particularly for the marginalized communities in Bangladesh? Anyone who wants to respond, please start. I would like the civil society members who are present here to respond to this. Hossein, would you like to go?
Professor, can you please rephrase the questions again? This is sometimes broken. Yeah.
Okay. How can we reimagine the health systems not just as service delivery platforms, but as agents of social transformation and economic empowerment, particularly for the marginalized communities in Bangladesh?
Yeah. Yeah, fantastic. Because the service delivery systems already, Professor Dr. Shana Chaudhary Madam already shown that when the service delivery system there is in Bangladesh, primary healthcare system, secondary and tertiary healthcare systems, right? So when people come to there in every Upazila health complex, people always want some free medications. I think all of the public health specialists will be agreed on that. People don't love to like advices. And even though doctors, I'm also the doctors and all of the doctors also be there. Some clinicians, provide the treatment and also there will be the advice portion, but they are completely emphasis on the treatment portions. And they tell the patients, you have 3 medicine you need to do before meal, after meal, but there is a lot of the advices. And even though a lot of the template are right now we are getting, they just get it into the prescriptions and they don't even read these advices. I've been told the patient that you should have to be obey this. Just give an example. We all know if the non-communicable diseases, there is a 3D, the diet, drugs, and the discipline, right? But all the pharmaceuticals, even though all as a physicians, I think it's a live programs, but we all focuses on the drug treatments, the insulin, metformin, everything else. But at least 150 minutes is the good exercise for the week, but we can't follow that, right? And even though in the diet, we are not follow the diet because it's no time for ourselves to provide this kind of the information to the people. So when people come to the Upazila Health Complex, how they will turn the changes? Because human behavior, you and me cannot change at a time because we can't change there. When we are a patients, when we go to the doctors or hospital systems, what we want to do? We just want to do to the doctors, even though the corruption has started from the serial number. Now, whatever we have doing, even though we have started 500 taka extra to get the serial number first, to get the treatment. Rather, if the doctors are not prescribing any medication and send the patient by advice, they even tell that this is a very bad doctors. And even though in Bangladesh, most of the people, even though my parents, they don't know what kind of the doctors I am. I told them I'm working on the public health, I'm working on the healthcare technology. I just wanted to transformation to the generations. Then my father told me why I would like to making you self as a doctor, not other person. My father not believing that what kind of the doctors I am. So this is the common things that need to be changed the people. So what we can do, that the concepts that it start from the schools, when the school students know how to control the diabetes or hypertension by the diet, by the discipline, so that they can transformation to the families and the communities. Start from the families. When we all know the 5 gram teaspoon, 1 teaspoon in the salt is enough for the persons, but only in the chips there is 13 gram of the salt. Even though a lot of the teacher and all the specialists also there, even though we are providing all these things to our students. If I give the example, when we are visit to our neighbors, even though our the good wishes during the time of the visit, what we are brought ice cream, we are brought a lot of the chips and something like that. Even though we brought the green leafy vegetables, no, even if we go to the another house, we go to the sweets. Even we know the sweet is a part of the diabetes mellitus. We don't take the green leafy vegetables. If you go to the other person with the green leafy vegetables, then your relationship will be the broken. So how we can change? The plan is very simple. We just started. Yeah.
I have to go. I have to go with that. Thank you. Wonderful, candid response.
Yeah.
Okay. The next set of questions are related to financing and political economy of health systems. So I would like specifically Caesar to respond to these questions, and then Professor Abu Jamil Faisal, and then Professor Kausar, and everyone is welcome. First question is, what innovative domestic and blended financing mechanisms can the Bangladesh explore to sustainably fund health system transformation while ensuring financial protection for the poor? Second question is, how do commercial determinants of health such as fast food, tobacco and environmental degradation intersect with the political economy of health system transformation in Bangladesh? And third thing is related to what you raised. What governance and anti-corruption reforms are crucial for building the public trust in health systems while ensuring that investment truly translates into equitable health outcomes? So I know I'm asking 3 questions. Please feel free to ask me to repeat it.
Thank you. So I would like to respond the second question, though I can respond first one, but I'm interested to respond the second question, like the commercial terminals. I think it's a very interesting question. And so far, last 30 years, we have been, heard about the social determinants, but now it's the commercial determinants. Like WHO has a lot of report about social determinants. So I think it's really interesting. So first of all, I would say, like when I was in class 6, so I had a proverb, one-page proverb that is prevention is better than cure. Unfortunately, I don't see any doctor in my life. They have actually practiced this prevention is better than cure. Unfortunate, but it's the truth. So now you have to actually prevent yourself. That's the important thing. If you want to save the people of Bangladesh, you have to prevent. Clinician cannot save the people, in Bangladesh. So you have to, that's why public health came out, right? So that's the important thing. So now, if you for example, in a Friday in Bangladesh, it's a public holiday. So we have a religious, prayer, like the Jumma prayer at 12, at afternoon. So if you see in our small kiosks, you then see a lot of people, lot of young people, aged people. What they do, they actually smoking, and another hand, they have a soft drinks. Very common, picture in Bangladesh. Why our government don't take an initiative to stop it? So, for example, without cigarette, without soft drinks, what would be happening in our country? Just imagine. Is there anything? Maybe 3, 4, 5 days people will shout, they will stop, right? Why government is not taking? Because we don't have that kind of leadership and governance. Very simple. We was very hopeful that we have got a reform-based, new government, and this government has no political agenda. So I'm sure that the government could, I thought that a government could take some unpopularist, policy. Unfortunately, I have not seen any single policy. So when you are talking about commercial determinants, I think we have to start with this simple thing, but this simple thing has a lot of impact. So first of all, I would say, as government is not taking an initiative, I would request people who knows it, like the person, you should protect yourself, right? That's the thing. And going to doctor in Bangladesh is one kind of curse. Who go, they know actually the overall system here. Like Dr. Hossain mentioned that we have to pay also bribe. So there is a lot of different issue, right? And we have only around 10% people has the health insurance. So I would say, let's start from ourselves. Let's keep your health safety, your family health safety. Don't think about the country. Thank you.
Thank you.
Okay. Can I respond, Professor Satpathy? Very,
Please.
For health financing, I think the time has come that we need to involve the private sector. I mean, whatever the financing strategies we have been talking about, I mean, it's very little that we have been involving the private sector. I'm sure that there are different ways and means of involving the private sector who can contribute to the financing of the entire health sector. The second is that we need to increase the tax base of all the bad things in the country. Like the tobacco, we need to increase further the tax on the tobacco, on the soft drinks, on the sugary drinks. If we can increase the tax of all those items, then that tax could be plowed back into the health financing system. Thank you.
Thank you. Dr. Hilaluddin Ahmed, do you want to respond to any of these questions?
No, sir. Thank you. Thank you. Already all questions answered given by our eminent professor,
Okay.
sir. Thank you, sir.
Okay. Dr. Kauser, do you have anything to add?
Domestic resource mobilization is a critical part. We know that Bangladesh will be turning into middle income countries, and day by day, we have to allocate our own resources. And we know that the government is increasing, but this time I think government has already cut down budget. But I'm sure that that's not going to remain like this. And we always blame about the corruption. And I know that most of the countries, developing countries, are suffering from the corruption. But some of the things, especially for the tax revenue, tax collection, this is a huge problem. Especially, I don't know. I'm not a person who is involved in this area or not even doing research. But I always feel that some of us, maybe who are working and have a bank account, decent bank account, not many questions. So we are the people who are paying taxes more or less reliably. But in our countries, not only we are always blaming the poor informal sectors that they are not paying taxes. These people are, earning income very low. But the people who are actually incoming high, having good incomes, especially business people and other professionals who are actually getting cash, they're not having transferring money through bank accounts, which is transparent. So how we will be able to change their mindset to pay the taxes, and especially and the government. I think our government is always strict. Their money is being transferred out of the country, pouring out of the country. There we are not going looking into it. When the country, money remains within the country, and we try to say that this is black money and this is white money. I don't understand the meaning of this. Please keep the money in the country. If our money goes to Singapore and they keep the money in Singapore, they don't say that it's a black money is coming. They are using the money in their own country. So why can Bangladesh have a strategy to keep the money in the bank for each of the business people who are making money, white or black, we don't know, but keep the money in Bangladesh? I think from that, we will be able to have some kind of tax paying within the country. And slowly, I think when the people have more money, they can pay taxes. But the poor people, still, I don't think they do have capacity to pay taxes. But for the middle class, upper class, they must pay the taxes which they're earning. This should be, very transparent. I feel ethically, this is very wrong not to pay the taxes to the government.
Okay, we'll go quickly to the third block of the questions, which is on climate, environment, and health nexus. As Dr. Sahnaz is an expert in that area, so I'll start her. I'll ask her to start. There are 4 questions in this block. First is, considering Bangladesh's vulnerability to climate change, how can health systems be redesigned to be climate resilient while supporting mitigation and adaptation goals under the SDGs? Second is, what actionable strategies can be adopted to integrate environmental health, planetary health, and disaster preparedness into mainstream health service delivery frameworks? And third is, how can Bangladesh leverage regional knowledge platforms and innovations to enhance early warning systems, heat health action plans, and post-disaster health responses? And fourth is, how can Bangladesh health systems adopt a multi-sectoral whole-of-society approach to fast-track SDG attainment, especially in the face of rising NCDs, climate change, and urban-rural health disparities? I know it's a lot of things, but I would like you to respond to it in a synergistic manner.
Yeah, there was a 4 questions. Wow, that's very elaborate. But I would like to amalgamate and answer the question. Yeah, like regarding this climate health action and health system, it's never not been incorporated properly. So I think regarding the climate change, how this is impacting on our health, I think the general people, even the healthcare providers, we do not really have an idea. Like in the other parts of the world, I'm not in Bangladesh, they have the consortium regarding the climate change, how they are trying to reach everyone, that how this, because in our country, like we are still in the basis of disease is oriented regarding the agent, that is virus, bacteria, and all this. But how this bacteria and virus is already related to the climate change, they have no idea. So I think in regarding those, we need to engage people of understanding that this climate change, which we are the one that is contributing into this climate change, and how we can mitigate and stop reducing the impact on our health. These kinds of information has to be distributed among the general population, and also, not only general population, in every sector of the population. So that is one strategy that can be taken. And when people can understand, that means in the policy level, how when this climate change is occurring, then we can stop. So the policy has to be very, very strong. I think even though we have a very good disaster response system in Bangladesh, but I think it needs to be more concrete, constructive, because now we are having a lot of reform. So I think this has not been discussed in that way, the climate change impact on health. So I think collaborating with other institutions or other countries who are now acknowledging these things, we need to more collaboration and partnership. I think then Bangladesh can have a resilient health system with incorporating the climate change and health and having the sustainable development goal. I think I talk about all the 4 questions. Thank you.
Thank you. Thank you. I think you have done a great job. Anybody else who wants to respond to that? Otherwise, we'll go quickly to the other, because Nepal panel has been waiting for quite some time, so they are getting a little impatient. So I need to now start asking the last series of questions, which is related to human resources and leadership. What bold policy steps are needed to address the health workforce crisis in Bangladesh, particularly the maldistribution, capacity gaps, and burnout among health professionals? Second is, how can Bangladesh cultivate a new generation of transformative health leaders who are system thinkers, equity champions, and stewards of planetary health? And third, what role can the public-private academic partnerships play in transforming medical and public health education to meet the evolving demands of SDG-driven health systems?
Professor Satpathy, can I?
Yes, please.
Can I answer this first? There are 3 questions.
Yes,
The
please go ahead.
Yes, the first part of the 3 questions is related to the leadership and transformative leadership. I believe that if the young generation leaders could be brought up and they may be trained up and they get the proper training to bring in changes in the entire health sector. I mean, Dr. Hussain actually mentioned about that the youths and the adolescents, if they are trained up, they can then transmit that information to their families and their neighbors, and then gradually this can go up to the top. And so these leaders could and then eventually become the transformative leaders for the health sector in Bangladesh. I thought of mentioning one other point that in Bangladesh, we are lacking in research. I mean, we need to do a lot of research. We need to initiate a lot of research, particularly looking at the issues which are our own issues. And if we can do some research and generate some evidence, then probably we will be able to take some plans and actions accordingly. Thank you.
Okay. And anyone else who wants to respond to this?
I think one important issue is that how can you motivate our young generation to stay in the country? Because we thought in our period that the generation was leaving the country, but even now that you can see that generations are leaving the country. I don't mind leaving the country, but I always believe that there should be a circularity, no? Brain circulation, not only brain migration. So even if they go back out, they should come back and they should work. And because we don't want the good brains that they are leaving the country. So what would be their motivation in the country? That's important. Because if you can't, make them lucrative, the areas to work here, it may not be our best place for them to stay, because the world is different now and thinking is different. So I believe that from the beginning of our life, some of the things are missing now. And we mentioned about our ethics in our health, but we don't mention in ethics in practicing in our life. So how can you practice some of the ethics beliefs that we have been carrying out for traditionally in our whole South Asia, that the way people live, the people embrace each other, but at the same time, how we could be connected to the global development? That is also important. This kind of thinking is missing, and this kind of research we need to do. We need to understand more that the keeping the young generation to make it more, contributing more, and even not the old generation. Faisal bhai, you are contributing a lot to the country. So don't think that older people cannot contribute. Everyone can contribute. But in our mindset, we have to be young. That's more important. And we should be all working together. And transformative leadership is a very different thing. And you cannot do in a day that you can transform a leadership. And I haven't talked a lot about medical education. I have a lot of criticism of medical education. I don't want to spoil the session at the end because we are almost ending. But I always believe that as we have raised the issues of transformative leadership, this is an attitude that we need to develop, because public health is not only for the health medical professionals to work in, because day by day I have been getting exposed to work with many different people in many different areas. I recently started to working with the people working in international relations. I couldn't believe that their way of thinking of health. So that perspective is needed for us to understand that why international relations is important in health, why this one is important for us. So we need to all work together to develop an ecosystem of leadership in our country. They can transform the health system. Not only the medical professionals can transform the health system. That's what I believe in. Thank you.
Definitely, I completely agree. If anybody else wants to contribute, please do it now, because we are going to close the session in just a minute, 2 minutes time. Otherwise,
Only thanking all. Thank you for a very good, exciting discussion. See you next time. Thank you.
okay, thank you, Dr. Mustaf. Yeah, wonderful. So, with folded hands, I would like to thank you, all of you, for coming on the stage of Global Consortium of Global Health Actors, Leaders, and Thinkers. The Global Consortium of Actors, Leaders, and Thinkers, the Global Health Forum, the Global Brain and Mental Health Forum, the World AIDS Forum, and the Bangladesh Institute of Innovative Health Research. Everyone would like to thank you with sense of gratitude, immense sense of gratitude and indebtedness that all of you came and you shared the entire evening, Sunday evening, and shared so much of wisdom and experience, which is very, very essential. We are running with one goal, that is one world, our world. So with that goal, we are also thinking about one South Asia. And that's the reason why this Global Health Dialogue series has started as with the first national open panel discussion with Bangladesh as the first panel discussion. So it was a wonderful and terrific discussion. I wish I could, pick your brains a little bit more, with a little bit more time, if we had that in our hands. But unfortunately, we have to, as all beautiful things come to an end, it has to come to an end, and we have to now go quickly to the South Asia panel, starting with the Nepal panel. So thank you so much, everyone. The Global Advanced Certification Program is delivering to more than 870 participants, and then the International Workshop Series is learning delivery to more than 3,000 participants as on today. And all of you who have come together today to join the panel are now registered as the resource persons, the teachers of our participants, who come from 170 plus countries. So I would like to inform you that they will receive 2 certificates, and on those certificates your signatures will be printed as a sign of credibility and your a sense of gratitude to all of you. And therefore our admin team would be getting in touch with you. Please cooperate and oblige. And we would also like to inform you that we would be sending as a sign of token of gratitude, we would be sending a letter of appreciation to all of you so because you came on a Sunday evening and spent three impossibly difficult hours, but definitely you have spent it quite worthwhile. You have made it worthwhile by having engaged with us on such important topics of great importance, not just of national importance, but of global importance. Because after all, global health happens when national health is being taken care of. We do not engage with national health, and the global health gets affected. We can't just be talking about global health systems without taking care of the regional health systems, the national health system, the local health systems. So therefore, it's been wonderful on my part as the CEO and founder of Global Health Consortium to engage with all of you, and I look forward to all the future opportunities to engage with you again, in different capacities, so that we can make one world, the vision of one world and the vision of one South Asia a reality. And hopefully, together we'll be better and we'll do great things together. Thank you so much. Faisal, the rest of the deals. Bye. Thank you.
Thank you. Thank you
Thank
very
you
much.
so much.
Thank you.
Thank you so much. Thank you. Thank you so much.
Thank you to all our distinguished panelists from Bangladesh for the deeply insightful conversation, from strengthening health systems and policy reform to equity-driven strategies for SDG implementation. This panel has truly offered a roadmap for transformation rooted in evidence and ethics. We'll now move into our next panel discussion, this time with our esteemed speakers from Nepal, who will share their experiences and vision for sustainable health system strengthening in a federal and rapidly evolving landscape. Please stay with us as we continue this powerful South Asian dialogue, reimagining a healthier and sustainable future for all, health systems strengthening and transformation for SDG Agenda 2030 attainment in Nepal. We now turn to our Nepal National Panel with the eminent voices working across public health, policy, academia, and government. Our panelists are Dr. Rajiv Kumar Shah, Chair of the session, Professor Muniraj Chetri, Dr. Mahesh Kumar Maske, Professor Uma Koirala, Dr. Meghnad Dhimal, Dr. Surya B. Parajuli, Dr. Prabhat Khanal, Nirmal Kumar Upreti. Moderated once again by Professor Maheswar Satpathy, founder and CEO of Global Alt and Director, COE ACC PHP India. Professor Satpathy, we invite you again to begin this insightful panel on Nepal's health journey and SDG vision. Thank you very much.
Okay, wonderful. Welcome everyone. With folded hands, I would like to apologize on recording for the slight delay that we had. But I guess in every meeting, these things happen, especially if we are engaged in important discussions which can be left without doing justice to it. So thank you for your understanding and the empathetic cooperation. We shall begin now. I will begin with introducing the chair and all the panelists, and then we'll quickly start. So Dr. Meghnad is also here. Okay, I can see all the panelists. Great. So, right. So Professor Rajiv Kumar Saha, the chair of this session, is an associate professor in public health and international lead at the Department of Allied Health Professions, Sports and Exercise, University of Huddersfield, UK. Previously, he has worked as senior lecturer in public health, program director for MSc Global Public Health and international lead for the School of Allied and Public Health Professions at Canterbury Christchurch University. Also, he was a regular member of the Faculty Ethics Panel and University Sustainable Education Group at CCCU. He is a fellow of the Higher Education Academy FHEA. He is trained as medical doctor and have completed MSc in Public Health from Queen Mary and PhD from Canterbury Christchurch University in the UK. His PhD examines social and cultural factors affecting sexual lifestyles and relationships of Nepalese young people. He has worked with marginalized and disadvantaged communities and is particularly interested in global health inequalities and international aspects of health and education. His research areas include young people and social changes, sexual health, lifestyles and relationships, migration health, social justice and health, inequalities, maternal and child health, and internationalization in higher education. He has a humble H-index of 13 and cumulative citations over 800. So the panelist number one, welcome Professor Rajiv Kumar Saha to the stage of Global Consortium of Global Health. It's wonderful to have you. The panelist number one today is Professor Muniraj Chetri. Professor Muniraj Chetri holds the designation of RMC advisor at the current academic position rank of principal. He has a PhD in public health from Chulalongkorn University, Thailand. His major field of expertise is epidemiology. Professor Dr. Muniraj Chetri is a leading public health researcher in Nepal who specialized in public health and NCD-NTD and holds PhD degree in public health from Chulalongkorn University, Thailand. With extensive experience in healthcare management and public health, Dr. Muniraj Chetri brings nearly 40 years of expertise to National Open College. He has previously served as the principal of Chitwan Medical College, Dean at Karnali Academy of Health Sciences KHS, and Professor and Director of Health Science at Pokhara University, contributing significantly to the field of education in Nepal. He has 25 years of extensive experiences in conducting, leading, and supporting variety of public health research projects in Nepal. He is associated with Pokhara University and has extensive experiences in monitoring and evaluation of various kinds of national level health research projects carried out in the field setting. He has already provided his consultancy services to various national and international organizations. He is excellent in designing the quantitative survey research protocol and writing and sound report. He has a humble H-index of 9 and cumulative citations over 500. Analyst number 2, Dr. Mahesh Kumar Mashke. Is he here? I cannot see Dr. Mahesh Kumar Mashke. Yeah, has he not joined? He had joined though. I had seen, but I cannot see him now. Faisal, can you find Dr. Mahesh? No, he's not here. Okay. If he joins back, it's good. Faisal, can you please get in touch with Dr. Mahesh? He had said that we'll. Yeah, please do. Yeah, thank you. Okay. I'll leave it for now. I'll go there later. Because he was there for the most of the time. I'll go quickly to the panelist number 3, Professor Uma Koirala. Professor Koirala is currently working at Tribhuvan University, Nepal on a gender studies program. Professor Uma Koirala, please do not share the screen for now. Thank you. On a gender studies program, Professor Uma Koirala, PhD, has over 30 years of experience in university teaching in the area of nutrition, food security, and gender and social inclusion, JC. Professor Koirala is a postgraduate scholar of Ghent University, Belgium, in food science and nutrition management planning. Besides theoretical knowledge, Professor Koirala possesses excellent skills in policy analysis, policy formulation, and strategic planning, program management experience in gender audit, health, nutrition, food security, risk management, human development, especially women's development, population, and multidisciplinary approaches of study, including monitoring and evaluation in Nepal and abroad. Professor Koirala is a technical committee member of Nutrition and Food Security Coordination Committee under the National Planning Commission, Government of Nepal. Professor Koirala was executive committee member of Global Scaling of Nutrition Sun Movement, even, and leading a civil society alliance for nutrition, CSA-NM, Nepal. She is a member of National Development Council and apex body of National Planning Commission, Government of Nepal, and also a member of Independent Expert Group of Global Nutrition Report, GNR. She is based in different big bodies, different chair of different organizations. So since we don't have a lot of time, I'm just quickening it up. Apologies for that. Panelist 4, Dr. Meghnad Dhiman. Dr. Meghnad Dhiman is an environmental health scientist with over 20 years of research, teaching, and policy formulation experience working in Nepal, Maldives, Timor-Leste, Sri Lanka, and Germany as a guest scientist. His primary area of expertise is on environmental health, with more focus on climate change and health. Currently, he works as a Chief Senior Research Officer at the Nepal Health Research Council, NHRC. He is also an Associate Academician at Nepal Academy of Science and Technology, NIST, and visiting faculty of environmental health at Tribhuvan University and Yale School of Public Health, Yale University, USA. He served as a contributing author of 6th Assessment Report of IPCC 2022 and also serving as a commissioner at the Lancet Commission on Sustainable Healthcare. He is also recipient of Institute of Tropical Medicine ITM Scientific Excellence Award 2023 and also elected Fellow of International Science Council ISC since December 2023, which is the highest honor that can be conferred on an individual by the ISC. He has supervised several master and PhD students from Nepal and abroad. As a result of his academic work, he has published over 300 technical reports and peer-reviewed journals, including The Lancet, EMJ, eLife, and Nature. His Google Scholar citation accounts for more than 75,000 citations with an H-index of 77. He has given more than 100 invited talks and keynote presentations in Asia, Africa, Europe, and USA. Panelist number 5, who also I do not seem to find right now on the screen, please confirm me if he is here. Okay, Professor Surya, please, can you please come on camera? Thank you. Professor Surya Bahadur Parujuli. Dr. Surya Parujuli is deeply committed to community-based healthcare, striving to improve health outcomes and contributing to achieving universal health coverage, sustainable development goals. His extensive 14-year journey involves active engagement in academia, research, clinical practice, health advocacy. He has a doctorate of MD in community medicine, tropical disease from BP Koirala Institute of Health Sciences, MBBS from Kathmandu University and Masters of Arts in Humanities and Social Sciences from Tribhuvan University. And he has also completed a translation research fellowship supported by the US National Institute of Health, NIH, specifically the National Health, Lung and Blood Institute, NHLBM. He is now the head of the department and serves as Associate Professor of Community Medicine at Virat Medical College Teaching Hospital. He has contributed significantly to publication and he is editor of biomedical journals such as PLOS ONE, BNC Health Services Research, Virat Journal of Health Sciences, Purvanchal University of Health Journal, etc. So many journals. In clinical care and health advocacy, he conceived and has been spearheading an innovative community-based healthcare initiative called the Buddhi Ganga Health Survey. This program is directed at 12,000 households within the Buddhi Ganga rural municipality in the Morang district of Nepal. It has operated in collaboration with local government bodies since 2015. And he is currently leading the health sector for second provincial planning of Koshi province of Nepal. He has a humble H index of 10 and cumulative citations close to 500. Panelist number 6, Dr. Pravat Khanal, Associate Professor Nutrition, Faculty of Biosciences and Aquaculture, Nord University, Norway. Dr. Pravat Khanal is an Associate Professor in Biosciences. He holds a Master degree in Agriculture from the Robert H. Smith Faculty of Agriculture, Food and Environment at Hebrew University, Jerusalem, Israel. He has earned his PhD in Nutrition and Physiology from the Department of Veterinary and Animal Sciences, Faculty of Health and Medical Sciences, University of Copenhagen, Denmark. And Dr. Khanal is now completed Marie Curie postdoctoral fellowship at the University of Oslo, where he focused on nutrition and lipid droplet biology. His current research explores alternative nutrition sources to enhance the global food and feed security for the future. He has a humble H index of 16 and cumulative citations over 700. Panelist number 7, Nirmal Kumar Upreti. He is the President Forum for Nation Building, FNB Nepal. He is also President of NGO Federation of Kathmandu, Executive Member of National Network for Safe Migration, NNSM, Partner Justice Concern Law Firm. He is the founding President of Nepalese Law Students Association, NELSA, umbrella of Nepali law students around the world. He has 17 years of professional experience in the diverse working areas including human rights, migration, human trafficking, access to justice, youth, disaster development, peace and minority rights. He has completed LLM from Kathmandu School of Law and MA in English from Tribhuvan University. Mr. Upreti has contributed to establish the Youth Policy 2010 and has worked on peace process of Nepal by engaging himself in Maoist army reintegration process in 2012. He has worked with Foreign Employment Board, Ministry of Labour, Employment and Social Security as a manager and also worked with Ministry of Peace of Nepal on Maoist army reintegration program. He has expertise on community mobilization and community empowerment work and is also one of the initiators of pro bono legal service in Nepal. He has worked for a number of publications related to human rights, migration, governance, GBV and minority issues. Mr. Upreti is one of the Professional Fellows of Governance and Society of 2019 funded by US state government. He is also the Fellow of Asia Pacific Innovators Forum 2023. He is the Regional Director of UAE, Secretary of NGO Federation and Board Member of National Network of Safe Migration. So these are the humble and generous introduction. However, I am still missing Dr. Mahesh Kumar Maski, who was present at the beginning, but I cannot seem to find him yet. If he comes back, we would love to have him. It will be a shame not to have him. Okay, so with this, I welcome Professor Rajiv Kumar Saha to chair the session. We'll have the same format that we followed for the Bangladesh panel. We'll start with a 10 minutes presentation. Everyone will get 10 minutes to present their topics. And then once it is over, then we'll go quickly to panel discussion. So, Dr. Shah, please, the stage is yours.
Yeah, that's great. Thank you very much, Dr. Satpathy. Can you see my screen?
It's coming up. It's still, yeah, now it's up. Yeah, thank you.
Okay, so you can see my screen now. That's great. Thank you very much. Good afternoon and good evening to everyone. And for some of our participants, good morning, because I know, they are coming from different parts of the world. It is lovely to be here. And thank you very much, Professor Satpathy and your team for organizing this event where we are talking about the SDG agenda in terms of like Nepalese context. Also, thank you very much for all the participants who are attending at this time. I'm Dr. Rajiv Shah. I'm an associate professor at University of Huddersfield and also an international lead within School of Human and Health Sciences. For this presentation or for these panel discussions, we have been given this topic about reimagining a healthier and sustainable future for all, health system strengthening and transformation for SDG agenda attainment in Nepal. And what I thought was like, I'll just set the context so that all the other presentation could follow, and that will lead to the further discussions. So where I want to start is like, I want to say by starting saying that Nepal has made a remarkable progress in public health over last few decades that has reduced maternal and child health mortality. It has improved the immunization coverage, expanded access to public health services. However, the journey to 2030 to meet the agenda of 2030 is still far away from complete. There are persistent challenges which relates to unequal access to health services, underfunded public health programs, workforce shortages, growing burden of non-communicable diseases alongside the communicable diseases, and the issues around health equity and resilience that is still there. The Sustainable Development Goal, particularly health and well-being SDG 3, challenges us to think bigger and bolder so that we can act on that. They call us not just to improve the health outcomes, but to do so in such a way so that it is inclusive, people-centered, and sustainable for future generations. This means reimagining our health system, Nepalese health system, as a foundation for justice, dignity, and opportunity for all Nepalis, starting from the hills of the Kathmandu or hills of Humla to the plains and Terai of Madhya province in Nepal. In this presentation, I will briefly discuss about the current health system of Nepal, identify some of the major challenges what we face in the current health system of Nepal, and propose some strategic priorities in that health system which could possibly support us in strengthening and transforming that can help us to meet the SDG agenda. And that can lead us to sort of like have further discussions. So I believe most of you will be aware of the decentralization of health system in Nepal following the federalization of Nepalese into 2015. I mean, we say 2015, I would say recently, but it has been almost 10 years since we have been Federal Republic of Nepal. Now, each province has its own democratically elected assemblies at the province and local levels, and the charge is with them at the decentralized health system. Nepal has the three-tier health system, so the primary, secondary, and tertiary. So the first tier or the primary healthcare system, health system is at the community level and the ward level, which sort of like acts as the hospitals with less than 15 bed hospitals, and which is governed by local government and the municipal government at the local level. The secondary or second-tier health system is at the provincial hospitals, the health officers at hospital that is managed by provincial governments, and the third-tier or tertiary health hospitals are at the central level, or that is the central level health facilities that is governed by the federal government system. But regardless of whatever the health system is there, the point here I'm trying to highlight is we need to have a strong health system if we're really to achieve a Sustainable Development Goal 3, which is health and well-being, good health and well-being for all. Now, that is for every year. Also, it is not only the SDG 3. To achieve SDG 3, we also need to sort of like interrelate with the other SDG, and that is very much part of achieving Sustainable Development Goal 3, whether be it SDG 1, which is about no poverty, or SDG 4 about quality education, gender inequalities, or the other form of inequalities. That all contributes to achieving the good health and well-being. I mean, I'll give you some example. When people fall sick, they need to pay money out of their pocket. If that risk risks them being into the poverty that relates directly to the health no poverty SDG 1. Another example is if people is sick, that means like they will not be able to attend the school. That means they will not be able to achieve the quality education, and that is directly related to SDG 4. Similarly, I mean, if we really want to have a better strategy, reduce inequalities, then investment in health is not just about the social good, but it is also about the economic strategy. A healthy population can contribute to a more productive workforce, reduces the burden of diseases, and promotes sustainable growth in the country. And that is very, very important. We know there are many challenges, like in the first panel discussion, we discussed about some of the challenges, and when the professor was highlighting about some of the challenges, what can be. Nepal doesn't have any different. It is very, very similar at the South Asian countries. We feel we have a similar context. We have issues with the low public health financing, where the spend on the health financing is much lower than the recommended WHO health financing. The GDP proportion is much lower in that particular context. The sort of like the burden of non-communicable disease like diabetes, hypertension is increasing day by day, and that is alongside the existing communicable disease issues. So that means we are basically suffering from the double burden of disease rather than sort of like having that just non-communicable or communicable. Another is the newly sort of like established federalization. That means like the referral system within the health system has become much more challenging, and that has created additional problem in some particular contexts. Now, colleagues, it will be quite good to discuss about it. What are the challenges and opportunities that has brought in as a result of federalization, and that can be one of the good topic for the discussion possibly. Similarly, I mean, we still have that unequal access to the healthcare services. Backing from the rural and marginalized communities are still struggling to sort of like get the healthcare access that could be beneficial for them. And then there is that brain drain, which again the former colleagues were talking about. Many of the Nepalese doctors are trying to go abroad, and it's not only about brain drain, but also about like how we can make it circular. And I like the comment from the previous panel. It's about like how we can bring them back so that we can stick to the specialist skilled worker that is already there. And then there is that natural or sort of like natural disaster and vulnerability that bring in. And we have seen that as an example post 2015 earthquake. Then there has been like regular monsoon rain that brings in different types of sort of like issues. And then we had COVID-19, and we saw like how it can bring the risk to the health system. That is very, very important part to consider. But then there is a way to overcome it. And sorry, before that, I just want to highlight Professor Padam Simkara, who is at University of Harrisville, and his team as part of the Nepal Federal Health System team. They did quite a big study, and they have discussed in much more detail about overcoming the challenges that Nepal health system is facing during the federalization. And I would recommend every colleague to read that paper if you have not done so. And it sort of like highlights some of those challenges, but also talk about like what can be the way to overcome it. So quite a good research done by the team there. But now coming back to how we can overcome those challenges, and this is nothing new. I'm sure all of you know this six pillar of the WHO, and we all talk about that. The colleagues previously talked about like the sort of like gaps in what the six pillars are, and the community engagement is not part of that. I completely agree with that. I mean, also this is a starting point, and if we start from somewhere, this is the best way because this is recognized, this is validated, and this is what we can start with. But of course, when we are thinking about the six pillar in strengthening the health system, I think we need to talk about at least these four key points, in my opinion. It needs to be cross-cutting, and we need to think about these four key points that can highlight or enable the health system changes in Nepal. The first one is a strong political leadership and intergovernmental coordination. I mean, I'm sure panelists and many of the audiences will understand what I mean about saying a strong political leadership. I mean, this is absolutely necessary, regardless of wherever the political affiliation is. The strong political leadership can give us the direction of where we want to move, and that is important. We had discussion about community engagement and health literacy. Absolutely. I mean, no health system strengthening can happen without the community engagement. I mean, it's a high time we talk about the co-production and implementation, and that needs to come through the community engagement, and that can basically strengthen our health system because it is about starting with them. And the other two is about the partnership and collaboration, and I'm very pleased to see Professor Satpathy bringing colleagues from around the world together for this partnership and collaboration, and that can give us a chances of knowledge mobilization and exchange in our knowledge, and that will be quite strong. But lastly, no discussion will be complete without digital health and the ethical use of AI. We talk about the use of AI, but I'm talking about the use of ethical use of AI. That is very, very important. It's not only about using artificial intelligence, but how we can use or integrate the ethical use of AI within the digital health innovation. That will be the primary aspect of how we can make the changes within the health system. I will stop there, and then I think I'm expected to sort of like start inviting the panelists to share their presentation. And based on a little bit of conversation, what I've seen on the chat, because of the time and other thing, what I'll do is like I will bring some of the colleagues up front who has to leave midway through, and hopefully still will have enough time to discuss about the topic in much more detail. So on that context, I would firstly like to invite Dr. Pravat Khanal. So would you like to go first? Because I think you have to leave, so I'll start with you, and then I'll invite some other panelists as well. So Dr. Pravat Khanal, the board is for you.
Yes, thank you. Thank you very much for this opportunity. I will try to share the slide and just to highlight what I'm focusing on in terms of research lately. If you can allow me, maybe I will just go with the screen first and share, and then let's see if I can find something here. I don't know. Can you hear me and can you see the slide? Could anyone confirm? Yeah, you do that. Yeah. What I'm focusing on is really rethinking about the nutrition for future food security. I was trained on nutritional science. It's mentioned earlier in the introduction at the Hebrew University of Jerusalem, where I learned about the basic nutrition after having my bachelor degree in agriculture from Nepal. So where are we going to really find the nutrition solutions? Is it at the supermarket, or where do you find the healthy options for that? Sometimes we talk about the many public health nutritionists. My wife is also public health nutritionist. We talk about this all the time. We have focused a lot about the where to find the healthy dietary options in the supermarket, and find the best formulation so that it can really improve your healthy status. But still, we do have quite a lot of problems in the world. I'm really focused on non-communicable diseases such as obesity and associated metabolic disorders. And it doesn't matter in the Western world or in other developing countries, the issue of obesity, for example, this is rising and rising. And it is not in just in one particular section, for example, both male and females. Then during my PhD at the University of Copenhagen, what I discovered is that, it was already known that the obesity actually begins on the plate. What I confirmed and through the animal model, that obesity actually begins on the plate of your mothers. So that we call or nutritional programming. So that I confirmed in an animal model, sheep model, by exposing different sort of nutrition regime to pregnant animals and following of their young ones after birth, a sort of giving and pre and post nutrition interactions. Then I went to do further study on lipid metabolism at the University of Oslo and using the beautiful mouse model and giving a different diet, including high-fat diet. And I also look into the exercise in mice. I don't think you can actually see this, but this is a tiny treadmill for mouse where I trained the mouse and they were running, but they were also exposed to very high fat, unhealthy diet. So then it was further confirmed from my findings that exercise is good, but if you mess up with your diet, it doesn't help. So that is what I found at the University of Oslo. And then from these studies, I sort of published a concept that we also see sort of rising prevalence of obesity in Nepal. Is it just what you eat, or it is just your earlier generation they were eating? So I hypothesize that there is also should be a mismatch between, if we are talking about the people are migrating from rural areas to urban areas, there is a existing pre and postnatal nutrition interaction, unfortunate interaction, that also perhaps contributed the rising prevalence of obesity in Nepal. Then my late research has really focused on looking into the alternative nutrient sources. Here in Norway, I focus on mainly on seaweed or macroalgae. And in Nepal, through my collaborative project with 2 universities, I focus on one of the aspects is freshwater aquatic plants. What are the nutritional values there? Can we find the health promoting compounds there? Can we promote that? So those are the issues really I'm focusing on. I'm not going to go into details on that. And other aspect I'm looking here is not just the freshwater plants or macroalgae, but also the insect. Insect should not be new for us, coming from the South Asia or from that region. Here at the university, in our university, I have established a research facility to really look into the nutritional values of the insects. And in Nepal, we have also established the insect lab at the Agriculture and Forestry University to look into the different bio-waste, circulating the different bio-waste into insect product, for example. And recently, I also challenged the traditional hypothesis where we talk about only plant-based fats. So plant-based fat sources, they are the only healthy fat sources. And in this insect, for example, that we are looking, it also contains 30% fat and more than 75% unsaturated fatty acid. And I try to compare this, and then I sort of quote the title, they are also like animal avocados. You can, in every individual fatty acid, they are actually matching beautiful. We are ignoring, but they are also important fat sources. And I have a collaborative project ongoing now with the Kathmandu University and Agriculture Forestry University. We are focusing on macroalgae, freshwater aquatic plant, but also the different 40 different insect species from Nepal. Our PhD student, he traveled to Nepalese mountains and Tarai regions to collect the samples and to find out, I mean, to also, everybody is talking about a black soldier fly and yellow mealworm, but we also want to show that there is a knowledge in developing world that can actually, we can bring that into the world stage. So we are hoping to find the new candidate species for future food and feed through this project. And I have a different collaboration with the European Union funding, also the North-South collaboration, although we also have a South-South collaboration component into that project, and also the different universities and industries that I have collaborated with this. I stop now, and then I'm looking forward to the discussion.
Thank you very much, Dr. Pravat, for completing a very interesting study. And as you rightly highlighted, Diet is one of the big component in contributor towards the non-communicable disease, and with the rise in non-communicable disease, it's more important that you are doing such studies, and then possibly that can transform into minimizing some of those issues. Okay, without further ado, I would like to invite Dr. Meghnad Dhimal for his presentation. It's lovely to see you, Dr. Dhimal, again, and over to you now. You are on mute, sir.
Thank you so much, Professor Rajiv, for the opportunity. Sorry, my voice is a bit off today, but I try my best. Let me share my slides. Is it visible now?
It's coming. Yeah, it's visible now.
Okay. Thank you so much, everyone, for bearing with me. And I just highlight the progress on health-related SDG in Nepal, maybe in few minutes, as per the instruction given by the organizers. On this topic, let me just start from the Sustainable Development Goals and overview. We all know that before the SDG, there were Millennium Development Goals, but these were very specific. But the SDG is very inclusive, which has covered every agenda and has introduced the concept of holistic approach and also partnership. And compared to the MDG, this applies to all countries, whether it's rich or the poor, although each country is expected to push towards the different target in line with its own priorities. So, though there are the 17 Sustainable Development Goals and 169 targets and 232 targets, but these are interconnected, and we need an interdisciplinary approach to track the progress. For example, there are the triple planetary crises, that means climate change, pollution, biodiversity loss, and also economic inequality, sustainable consumption, peace, justice, and many others. They're interconnected. So when we track the progress means we need to also take the consideration of those factors. So we all know there are the 17 goals, 169 targets, 232 indicators, and there is a volunteer evaluation of these SDGs. Every year or every alternative years, the country come up with the volunteer evaluations, and the report of 2024 is already in public domain. So the SDG Progress Review 2024 shows that only 17% SDG are on track or the target which can meet, and 18% had the moderate progress, 30% have the marginal progress, 18% stagnation, and even 17% are the regression, going back than the baseline, right? So the 2024 progress assessment revealed that all is severely off track to achieve the 2030 agenda, and because of the latest geopolitics, this SDG agenda is much more hampered by ever before. And interestingly, if you see all the SDGs, 17 SDG, the SDG first in the hunger is worst one. I mean, no any track or target made. It's only marginal or the moderate progress. And if you see the second goals, that is the stagnation or regression is the highest one. But the good news is that if you see the SDG third, which is the health and well-being, at least they are on target, on track of the target, and least on the stagnation or regression. That's the good news. And if you see the SDG progress and challenges from the Nepal perspective, overall performance of Nepal in country ranking is 95 among 167, and country score is 67.1, which is better than the regional average of 66.5, right? And if you see all the SDGs together, means majority are significant challenge, and also the challenge remain, and very few are almost known as the SDG achieve. Means we need to work a lot to achieve all these SDG in the case of Nepal. For example, let me share one example of maternal mortality. The maternal mortality rate of Nepal was very high. If you see the Nepal Family Health Survey of 1996, it was 539, and gradually it is declining. And as per our latest census of 2021, it is 151 per 1 lakh live births. And if you see this trend, means it is still very difficult to achieve of 70 per 1 lakh live birth by 2030. And the big question is of the inequality. Still in some provinces it is more than 200 and other places less. So equity is a big issue. Similarly, if you see the deliveries conducted by the skilled birth attendants, right? The current achievement is 80% and the SDG target is 90. So we are at least near to achievement. That's a good sign. And if we see the child mortality, especially under 5 mortality and the neonatal mortality rate, we have almost stagnant. And there is a big challenge, especially to achieve the neonatal mortality rate of the country, because it's almost stagnant in the last 10 years. So what are the then issue or challenges? First is that we have a clear epidemiological transition, and we are suffering from the triple disease burden, and also a disaster prone country, so which is the hotspot of triple planetary crisis, like our colleague in Bangladesh mentioned. Means climate change, for example, is impacting to the every sphere of life, whether it's agriculture, it's water or biodiversity or the health, right? And huge impact. Next is the inadequate investment in the health sector. As per the WHO recommended, it should be 10%, but still it is less than 5%. So deficient in funding is big issue. Out of pocket expenditure is still high, more than 50%. It is because of the low coverage of national health insurance, still around 30%. And referral system had to be institutionalized, right? And next is the equity concern in the healthcare access and health indices, very important in terms of geography, economics, and education. So what could be then way forward? Means health sector alone cannot do to achieve all this SDG. Means health beyond health sector is very important. Means we need to promote health in all policy to address the wider determinants of health. And health service readiness for the epidemiological and demographic transition is very important. For example, 73% of the disease burden is attributed by non-communicable disease. But if you see the funding, means less than 1% of the health sector budget. So we need to increase the readiness of our service provider, policymaker, and program managers. Means we should continue the budget on the communicable matter nutrition disease, but in the same time we need to increase the investment on non-communicable disease. We need to address the inequity issue, and also we need to improvise and expand the coverage of national health insurance. And finally, government alone cannot do. Means we need to develop a strategy, partnership, and collaboration with the private sectors, providers, and the non-government organizations, so that we can achieve those SDGs. Thank you so much.
Thank you very much, Dr. Dhimal, for this lovely presentation, and I think you showed us where we are ending up by 2030. I mean, it's quite good to see that 17% we are making progress, but it's really depressing to see that there is 17% of the targets in regression, and that's
Yeah.
really worrying, and stagnation caused due to that. But also, I think one of the other things which you highlighted, I talked about double burden. You are talking about the triple burden of the disease, and that's really right. And yeah, where we go from there. So thank you very much for putting those way forward. Okay, in that case, I'll bring now or invite sort of like the third panelist of the session, and I would like to invite Nirmal Kumar Uprati. Please, would you like to present your Interesting.
Oh, sorry, Maheswar, can you help me to share my slides? There's some problem coming here in my index.
Yeah, the slides have been shared for you, don't worry.
Okay.
Okay.
Okay, please second slide.
Okay, you are ready to go, Neil.
Oh, okay. Okay. Thank you for this lovely opportunity to share my perspective. I'm going through the what are the legal and human rights lanes of the health issue of Nepal. So we can see that. Okay, so we have a very good constitution in our hand, like constitution of 2015 Nepal. So we have 31 fundamental rights. Among them, the Article 35 of right to health care also talks about the free basic health services and emergency health services to everyone. It also talks about the equal treatment and equal health services to everyone. Also, it talks. So, Article 38 of right of women, it has also included reproductive health rights and also on the right of the children under the fundamental rights. It has also talked about health and upbringing of child from the government and family level. So it also talk about Article 40. It also talk about the right of the Dalits. So it's a special provisions for the right of the Dalit communities and special care on health and social security issues. So under these constitutions, we have also mandated that we also have the remedy measures if somebody if the state is not able to supply the fundamental rights to the people, then we can go through the Article 133 and 144 for the remedy provision. So it is we can see that it is a very good points to be noted. And we to accommodate the fundamental rights and constitutional rights of the Nepal, there are different plans, acts, and policies have been developed. We can see that there is a Public Health Service Act 2018, which also talk about the emergency health services and basic health services to everyone. Also, we also have the Consumer Protection Act 2018. It also talk about the preserving the consumer health. We are not allowed to play with the health of the consumers in the food items. We also have the very interesting and very important law, the Safe Motherhood and Reproductive Health Rights Act 2018. It is especially focused to the mother, children, and parental rights, including the responsibilities of the local to national government, because we have three tied up governments now. So all three governments had some responsibility to care of this maternity health and sexual and reproductive health, including the LGBTIQ people rights. We also have the newly established, like 7 years before, we have the civil code and criminal code. Civil code also talks about the equality before law. That also can be related with the health rights of the Nepalese people. There is also a criminal code, and it's also talk about we are not allowed to spread the communicable disease, and it was really attractive at the time of pandemic. And so if people talk about this law, this section of the criminal code, and also there is a punishment provision if somebody is doing somebody is making the communicable disease, for example, COVID or HIV, everything. So they can be punished for 3 to 10 years imprisonment or up to 1 lakh fine. So we also have Infectious Disease Act 2020, but which is very old. That is 16 years before that. And at the time of pandemics, the law was attracted, but it was not that much sufficient to cover the present need of this at the time of pandemic. So it was amended, and there is one ordinance came in existence to to care about this Infectious Disease Act, which also control the and also which also control the communicable disease spreading, and also the punishment provision. We also have the Local Government Operations Act that has also mandated the local government of Nepal to to look after some the cases of the health issues. We also have policy quality assurance in healthcare services 2064. Next. So we also have now recently, we also have a National Health Policy 2019 and Nepal's Health Sector Strategy Plan 2022 to 2023. It also in line with the Constitution of Nepal under the fundamental rights, rights to the basic health services to everybody, and also it also provide the services to every individual with the drugs, diagnosis, and skilled manpower. It also promote the participation and involvement of the partnership, which also lie with the SDG goal. SDGs goal, and also invite NGOs and health service providers to manage the partnership to get the rights of the people and to achieve the SDG goal related to health rights. We also have a National Health Financing Strategy 2021-2033. It also aims to reduce the out-of-pocket expenditures. We can say that because of this out-of-pocket expenditure, we are not able to cover the universal coverage, and if we talk about the research reports, it says that every year like around 0.5 million people going under the poverty line because of the out-of-pocket expenses. Next slide, please. So Nepal is one of the very famous. We are in very ahead of ratifying the international human rights standards, and in the South Asia only we are in the top, and we have already ratified the more than 24 human rights treaties. So and also the UDHR, we are also party of UDHR. Article 25 also talk about the adequate living standard, economic, social, cultural rights, where we are also party. That also talks about the sustainable standard of physical and mental health, and also the elimination of all forms of racial discrimination. Article 5 also talk about the public health, medical care. Also, CEDA Article 12 also talk about the equality and special care to women, sexual and reproductive health, and that is also in line with our SR Act 2018. We also are the party of the CRC Child Rights Conventions. Article 24 talks about the special health care services to children. So we are also the party of 2030 SDG goals, goal number 3, universal health coverage, and our previous speaker has already covered the many things about the SDG, so I do not go on it. So next slide, please. So what are the government services under these different plan, policies, laws, and constitution provisions? So if we talk about the free availability of medicines, then we can say that 96 kind of medicines freely available. So the government is also supporting the 9 kind of diseases, for example, cancer, heart disease, kidney dialysis, and we also have a free OPD and basic health checkups in the district and the health post of the different hospitals. And also we also have health insurance program that also our previous speaker talk about, and we have also 3,500 rupees the family insurance programs. That is also the positive points from the government perspective to get our sustainable goal, and also to in line with our fundamental rights of right of health. So next slide, please. So what are the challenges? These are the mentioned before. I have talked about the good points. What are the highlights? What are the good points in the legal and human rights perspective that Nepal has done? But if we go like civil society organizations that I have been working since long with the community, and if we talk about the community, go to rural places, we can see that there is many issue of the corruption, policy gaps from 3 types of governments. We can say that poverty, medical poverty trap, and this we can also say there is the access to health services is not available everywhere. There is a gap between the city and rural areas, remote areas, and the well facilitated areas. There is also that people mostly don't talk about information about service and health education. For example, the government is providing 96 kind of different medicines freely from the health post and different government hospitals, but many of the people who are in the community and even many educated people don't have understanding and information about the health services that government is providing, and providing the free medicines to the people. So there is also issue of the quality health services. Like if we even there is a availability of the free services, and if we go to the health posts and hospitals, people then and they respond that there is the medicine are not available. We also sometimes get the date expired medicines. That is the problem. And if we also talk about Nepal is one of the most migrant, the remittance receiving country in the world. And if we talk about the health of the migrant workers, we can say that many people are being injured in the abroad. And if we talk about the recent data, we can see that every day, every fourth dead people of the migrant Nepali workers are coming to the country in the box. And also we are also talking about, we also have to talk about the organ trafficking. So people are selling their kidneys, the different organs, and that is also the big problem for the Nepal. We also have the cases of malnutrition, and now the recent days we can see the many foods that is highly pesticides, and that is the very bad for the health issue for our health. And air pollution is one of the core issue. The existing issue of in Nepal, and Kathmandu is being the one of the most polluted city in many news and in many times. We also have the emerging mental health problems, emergency situations such as pandemic days, climates. We didn't have any good action plan. Even at the time of pandemic, we done one research and we found that Nepal has done nothing to respond to the pandemic and its outbreaks, and also its impact. There is also sexual right health issue. Even the pregnant women are being died at the time of pregnancy, even though there is a good services by the helicopter rescue, but that is not available and not noticeable for everyone. So there is also issue of minority communities, and also intersectionality issues with the health is prevalent in Nepal. And the budget allocation recently, the fiscal year 2025, only the 4.88% of total budget is allocated for health services, which is not sufficient. However, it is slightly higher than the last fiscal year, but the provided health budget is not sufficient to address the many problems and many human rights and the legal commitments Nepal has done so far. Thank you.
Thank you very much, Advocate Nirmal Upreti. I think you provided some new insight about how to look at the same issue from human rights lens, and thank you very much for that that talk. Before going on to my next speaker, I would just like to request to the panelists who have presented, if you have got a little bit of time, please do stay. We know we are running a little bit of late, but if you can stay a little bit further after all the panelists has presented. We have got 3 more panelists to present, so about 30 minutes more presentation, and then if you can stay a little bit longer, that will be really appreciated. So thank you very much. So on that note, I would like to invite Professor Uma Koirala. The floor is yours, ma'am.
Thank you very much. Thank you. It's not going to be bigger.
If you can present on the slideshow, then that will be. So on the top of the screen, there is a slideshow.
Okay. And share?
Yeah, it's shared. We can see your presentation. So if you click slideshow and then play, then that'll do.
Okay.
So yeah, on that row down. Yeah, transition animation slideshow.
Slide control sites.
ma'am. Review भन्दा यतापट्टि.
Review भन्दा
यतापट्टि स्लाइड शो छ नि यो.
तलको लाइनमा. Yeah, transition. हजुर.
Slide control.
हजुर. Slide so like click गर्नु.
हजुर. Yeah, no.
Otherwise, you can start.
You can just press F5, ma'am.
F5?
Yeah.
Okay. No, it.
Okay, it's all right.
I don't.
Slide is visible, no problem.
Okay, Hazel, why don't you present? That would be good.
Where it's gone? I don't know.
Below also there is a button on which you should.
Animation र slide show को review को बीचमा छ नि म्याम slide show भन्ने. Animation र slide review को बीचमा slide show भन्ने छ.
Yo upper मा slide.
त्यही हो.
Yes, coming.
Coming?
Yes. It's all right.
It's all right?
Yes, all right.
Visible? It's visible.
Visible.
Okay, okay. Thank you very much for your patience. First of all, I want to express my sincere gratitude to the organizer for tracking and inviting me in this important forum. Now it has been so late, and now I'm just entering to my subject. As the continuation of MDG achievements and keeping control, central value of no one left behind, UN launched SDG with 17 agendas and 169 targets that we all know. The main aim of the SDG is end poverty, protect the planet, and ensure prosperity for all. Nutrition is a cross-cutting issue linked to all SDG agendas. There is no one agenda, I think it is not linked with nutrition, though directly or indirectly it is linked with the agenda. But I think beside the linkage, we have not realized or perceived that nutrition is a core value of the whole program. Achieving these SDG goal, nutrition is a cross-cutting, and Nutrition for Growth Summit has kept nutrition in the heart of SDG development. Also, so nutrition is interlinked with all the SDG agendas. For example, if let's say about the goal number 1, no poverty, as my earlier colleague, Dr. Dimal also mentioned that poverty achievement is very, very poor in our indicator. In my prospect, if we say about the no poverty, poverty will eradicate if a person is well grown up, well educated, skilled, and can work with his full potential and capacity. So these characters.
Hello.
Sorry. These characteristics can be what achieved if he can work with his potentiality and can eradicate his or his family or communities poverty. So similarly, if we say about the zero hunger, it spell out about the productivity, farmers, production, and eradication of hunger, blah blah blah. But if the person is not well, he is sick, how the farmer can contribute in the farming, in the farm with his full potential. So with all these 17 agenda, nutrition is so embedded with these agendas. So we need to be more cautious about these things, because nutrition is always, as I already mentioned, that it is always in the base of the foundation.
Just a minute, ma'am. Yeah, we can't see your slides, so you are on the same slide. So it looks like your slide is not running. But it's completely fine if you don't want to use slide, because your talk is quite nice. I think you are running it smoothly.
Yeah, it's okay. I think I'm quite clear about these things, because all are working with the nutrition and health issues, so it is more clearer for all. Yeah. Anyway, may I go?
Yep, yes. Please continue.
Okay, thank you, but sorry for inconvenience. Why the nutrition matters, I just want to say something about this. As I already said, that the foundation of human health development and economic productivity is based on the nutrition. And so for all these things, nutrition is a prime thing. Similarly, if people suffer from the malnutrition, it's a lifelong damage in its various form, such as undernutrition, wasting, stunting, underweight. It is the very critical indicator for the prosperity of the country. Similarly, micronutrient deficiency, it is a hidden hunger. So there are many setbacks from these micronutrient deficiencies, such as anemia, zinc deficiency, iodine deficiency. These are the critical issue in our health arena and in our health sector as well. And similarly, overweight and obesity is also the cause of malnutrition, which is a great loss of human capital and human productivity as well. So good nutrition always support improved education, employment, and health outcomes. And nutrition is maker and markers also. It is a popular person. So nutrition is makers and markers. So we matter in nutrition for all development agenda the country. Now, a little bit we talk about the SDG related nutrition progress in Nepal. As Dr. Dimal already said about these things, the SDG and its nutrition related performance is not so encouraging, though Nepal has made impressive progress in reducing child malnutrition, maternal malnutrition, reducing stunting. Let's say it's a good example of stunting reduction. The stunting prevalence went down by 11% points from 36% to in 2016 to 25% in 2022. So this kind of achievement is a great, and national strategies are all aligned with all the SDG agenda, but challenges is still remain in not only rural but in the urban and among marginalized communities. There are a lot of government initiatives such as multi-sectoral nutrition plan, nutrition-sensitive agriculture policies, disaster preparedness policy, and other various policy and programs are intact there. But the report of SDG progress shows that goal number 1, no poverty, has gained only 8% progress. Goal number 2, zero hunger, 8%. It means poorly performing agendas. And another goal number 10, reduce inequalities, 10% performance. So these are poorly performing agenda, which is quite critical, and most of us realize that these are the important issue. So having said that, though all the challenges of health sector are already explored by our dignified speakers, panelists, I just want to showcase some of the nutrition related SDG challenges. One is inequitable access to nutritious food. These are becoming more expensive and out of the reach of common people. And climate change and environmental degradation is also a big challenge. Poor water, sanitation, and hygiene is also taken as a barrier. This is the bad habit. We still struggling to improve those behaviors. Another challenge is displacement and migration, which makes people vulnerable in each and every sector of their life. And another is weak health and food system. And another major thing is very low awareness among people about nutrition and quality food. So these are the major barriers, beside many other barriers also. Here we can improve the situation by enduring advocacy for nutrition, integrate nutrition into all multi-sectoral aspect of the programming, and investment need to be increased, as we know that $1 investment returns $35 in future. So this is the smart investment as well. And also we need to get in gender empowerment and gender equality process, though despite constitutional safeguard, we marginalized people such as rural women, including religious women, people with disability, member of LGBTQ plus community, and Dalit, including marginalized community, continue to encounter significant obstacle in accessing state services and achieving equality. And also needed strengthening governance, data, and accountability. And another major action need to be is the political leadership. I just stop here.
Okay. Yeah, thank you very much, Professor Koirala. I think it's quite good to see that there are some of the parallels which you are drawing from all. But yeah, nutrition as a cross-cutting issue linked to all SDGs is definitely an important point to remember. So thank you. Okay, I will invite another panelist on that note, and Dr. Surya Kumar Parajuli. Lovely to see you here, Dr. Surya. Would you like to present?
Am I audible?
Yes, you are, Dr. Surya.
So I'm traveling, I can't open camera. So good evening, everyone. So I'd like to request, now I can say my co-presenter, Faisal, is with me since last 10 weeks, okay? So I'm habituated to be with me. So good evening, respected panel members, distinguished guests, and all the participants from Nepal and abroad. So this is the topic considered for Nepal panel discussion, and interestingly, I tried my best to give some ideas regarding medical education in Nepal, and this is just my intuition and some interest, and definitely supported by some evidence. So I want to give my clarity that this does not reflect any institution of my involvement. Okay, this is just my intuition and interest. Okay, so let me declare first, and this is one of the important topic to achieve the SDG Agenda 2030 in Nepal and abroad, and why we should know about SDG 3, because see, the SDG 3 clearly mentioned the good health and the well-being, okay? And Nepal is firmly committed to achieving the universal health coverage, as you all know, universal health coverage. And here we have participants, many participants from the academia as well, okay? That's why I'll try my best to share some of the, important components of WHO 6 building blocks. And in the broader context, SDG 2030 health agenda, at the road to that vision is not easy. It's very difficult. In our health system, in Nepal, is facing multiple interrelated challenges such as critical health workforce shortage, even in Nepal, India, and especially the LMICs, a persistent rural and urban divide, which is another major challenge, and skill mismatch that affects service delivery quality. So knowledge-wise, okay, our healthcare professionals, they are okay, but based on the skill, they are not quite effective to deliver their services. And definitely an education system not at full aligned with the community needs and the national priorities. So academia goes in one way, and the healthcare industry, healthcare services goes in another way. So this is the challenge. So at the heart of solving these problems, so we need to think about the medical educations. And if we reimagine effectively, it can become a backbone of a stronger and more equitable health system. So let me talk about the current scenario. Currently, we have over 24 medical colleges under different universities, and like Tribhuvan University, Kathmandu University, BPKHS, PAS, RAS, and there are almost more than 2,000 MBBS students enrolled every year, where almost 33% from the international context, especially from the India and other countries, and other paramedics. Yes, despite this growth of the medical colleges and student enroll for the health care teaching, but it's unevenly distributed even in context of Nepal. And another issue is the brain drain. Okay, the brain drain is the major challenge of low and middle income countries, including Nepal and India and Bangladesh and other countries. But our medical education training is largely focused on urban centric with the limited primary health care. Still, the primary health care is the challenge. We are talking about the super speciality, but beyond that, the primary care is still, a hidden agenda. The rural health and interprofessional collaboration is almost, lacking. The digital learning tools remain underutilized in the context of digital world. Still, we are not utilizing the digital learning tools and training tools in our medical educations. And another important challenge is being a faculty of medical community medicine. So community-based learning, which is essential in our country like Nepal, because we need to have community-based medical education, but we are just accepting our medical curricula from abroad. Okay, in the context of like we are producing manpower to work in the western part of the world, not from this part of the world. So what's holding us back? Could you please go to next slide, Hazel? Could you please? Okay, good. So see, what are the problems? There are several interconnected issues. Like our training is basically urban focused in limiting to the real, let's say, rural health challenges. So we are basically focused on the curricula based medical education, which is designed by from the abroad countries, and somehow it is there to practice in the rural healthcare, but in actual situation it is not done it, and it's fragmented. And another one is there is lack of alignment with the national health priorities of Nepal, such as like the upcoming issues, the mental health, non-communicable disease, health equity, health literacy. Okay, and another important in the medical education in context of Nepal is faculty development is minimal. Without continuous, let's say, continued medical education through training, mentorship. And another issue is incentives for or grants for the research excellence. So this is lacking in the medical, institution in Nepal. Another one is regulatory landscape is a fragmented. In context in Nepal, now we have MEC, Medical Education Commission. We have existing body like Nepal Medical Council, different universities, direct involvement of Minister of Health and Population, resulting, who is the regulator and who is regulating who is, responsible for what type of organization. It's a fragmented and the accountability is diluted. So this is the problem. So accountability is diluted is the problem. So could you please go to next slide? Okay, so reimagining the medical education, what can we do? So it's a time. Okay, because in this today's national panel discussion for Nepal, so basically I'm being an academician, so we have to rethink about the medical education. It's just not to be a theoretical based. It should be a practical action based, and it should be implicable in the context of Nepal. If I am talking about Nepal, so we should utilize our human resource in our country, not to produce for abroad. Okay, not for the global north. So we have to think about our country. So what we can do. So this is my intuition. Okay, there is no any research on going on for this, but based on some evidences, published evidences. So we need to revise the curriculum. It should be integrated. We have different medical universities in Nepal, and if we go through the different curricula, the mission, vision, and goal is different for different university. And somehow it is written the community responsive, community based, but see, it's not in actual practice. It's only few medical colleges or the institutions are doing it. And it's not SDG aligned competencies. So we are talking about the SDG, but our curricula was developed just before the SDG, okay, in the era MDG. So how should we integrate the SDG component in the medical education? It's not possible. That's why we need to revise the curricula to align with the SDG. Another one is Nepal. After federalizations, we have three-tier government, but still the concept of federalism is not well implemented, and there is still lack of, let's say, rural posting. There is still lack of community engagement and experiential learning. Another one is still we are not focused about to make the center of excellence, like which includes faculty excellence, both pedagogical or andragogical training and research capability enhancement. And I already spelled out in the previous slide, like despite having different digital tools and simulation based learning and the modernized education delivery, we are still using traditional technique to teach our medical students or health care professionals. And most importantly, the one of the important part is intersectoral governments. So after federalization, Nepal, we have three-tier governments: local, provincial, and federal. But see, the intersectoral governance, especially intersectoral health governance to govern, okay, to implement this governance, health governance, we need better health, better medical education, which is lacking. But the demand is ongoing, but still we are lacking for better, let's say, integration. And medical education reform should not happen in isolation. It should not be isolated. It should be a part of national health policy and workplace planning, but it is not. So our national planning is in its own way, the medical education in another way, the practice is another way. So it's all fragmented. So, but it should be aligned. It shouldn't be isolated. It should be interdisciplinary. We should follow the interdisciplinary approach. So next. Okay, so what can we do? Pathways to 2030. So as you look to 2030, because SDG target for which is one of the UN goals, so we need to have some. We need to meet some targets of SDG 2030. Let us commit to training the health professionals who are not only clinically competent but also socially accountable, because my subject is preventive in social medicine. So the social accountability, because now we are talking about the social determinant of health. Okay, so what we need to do? We need to equip them to respond the NCDs, mental health and the health equalities in the local, national, and the global context. We have to incorporate own health, planetary health perspective in the curricula, because we need to think about the planet, the own health dimensions, and we have to nurture our future medical professionals for leadership, ethics, and the system thinking. And definitely we need to strengthen, this is the most important agenda in Nepal. We need to strengthen the ties between local government, provincial government, and the federal government. So we need a bold approach, integrated approach in Nepal to produce healthcare professionals who stay in the country, who serve in the country, and transform their communities. People are transferring communities of USA, Australia, UK, Canada, not Nepal. So this is the problem. So what type of manpower we are producing to serve our communities and transfer our communities to align with the achievement of SDG 2030, or to just like sell our professionals to the developed countries. So to conclude, we need to reinforce the medical education, not just as a academic exercise, but we should have some strategic investment in the Nepal future sales. So my last slide is, so next slide, please. This is the last one. Okay, from vision to action. So what we have to do, we have to go for people-centered, community-centered, equity-driven, and system-responsive medical education. So let us invest, innovate. I want to highlight 3I, investment. Let us invest, innovate, and integrate, because a healthier Nepal by 2030 begins with how we train our healthcare providers today. So basically, being academician since last, let's say, plus minus 15 years, after bachelor or master, so I'm basically keen to develop such type of the healthcare providers so that we can invest, innovate, and integrate our healthcare providers of today and for betterment of future. So thank you very much. Thank you.
Thank you, Dr. Surya. That was quite interesting presentation. And of course, I mean, healthcare workforce is one of the building blocks of WHO health strengthening system. So of course, we need to take a look at that in more detail. The last but not least, Professor Muniraj Chetri, please, I would like to invite you to do your presentation, please.
So, good evening, namaskar, salam alaikum. Thank you, Dr. Rajiv, for providing the opportunity. Honorable Chair and all the distinguished panelists, Dr. Maheswar, I think he is not there, Professor Uma Koirala, Dr. Meghna Timal, Dr. Suryabadur Parajuli, Dr. Prabhat Khanal, Nirmal Kumar Upreti. And I would like to thank Professor Maheswar and the team for organizing this excellent program. Now, I think all the explanation are already given by our previous speakers, so I'm not going to talk much more. I will share only few of the slides, and I'm sure that I will complete within the time limit. Is my slide visible to you all? Hello?
Yeah.
Okay.
Yeah.
So then, can I start?
Yes, please. Go ahead.
So the topics, as we all know that reimaging a healthier and sustainable future for all, health system strengthening and transformation for SDG Agenda 2030 attainment in Nepal. As we all know that every country has given the popular slogan. Similarly, our country has also given the popular slogan. The slogan is Sukhi Nepali, Samriddha Nepal, Happy Nepali and Prosperous Nepal, by fulfilling the Sustainable Development Goals.
Yeah. Sorry, Professor Muni, sir, if you can put on the slideshow mode, then that will help.
Okay.
Thank you.
Is it visible?
It is visible, but not on the slideshow mode. So you can get on other slides as well. Yeah.
Okay.
Yeah, that's better. Thank you very much.
Okay. So, as we all know that we believe in and we are committed for the Happy Nepali and prosperous Nepal by fulfilling the 17 Sustainable Development Goals, but we are focusing on the goal number 3 and goal number 4. Goal number 3 says about the health and goal number 4 says about the quality education. As Dr. Sure already talked so many things about the quality education and different types of education, morality, community-based education, and all. So my topic is very simple, and we all know that Nepal's health system at a critical juncture, and there is importance of linking health system to the SDGs, and we are trying our best to do all these things. So I'm not going to repeat all these things. So we all know that SDG 3 targets related with the health, and we do have the National SDG Roadmap and Health Sector Strategy and localization of SDG targets in Nepal. And as we all know that our first national health policy was started in 1991. And again, we are a newly published national health policy in 2019, and which also relates with the SDG fulfillment. So as already discussed that we do have the 3-tier system, federal, provincial, and local levels, and they all are trying their best to address the SDG goals. So there are some problems. So I will talk only about the challenges facing the health system. That is, number 1 is the inequity in access and utilization, and number 2 is the human resource shortage. Number 3 is the weak governance and health financing, and number 4, climate vulnerabilities and migration pressures. We do have migration of talented human resources and migration of the even the workforce. And as we know that this all the building blocks explained by all the previous speakers, so I'm not going to talk. So as we all know that there are so many components of the health system. They are number one, concepts. They are health and disease, ideas, equity, coverage, effectiveness, efficiency, impact, objects, hospital, health centers, primary healthcare centers, health programs, and the persons we the providers are providers and consumers. And the aim of the health system is to develop the health. How we can develop our health and how we can develop our country is only fulfilling the 17 Sustainable Development Goals. As we all know that SDG was started in the year 2015. Now we are at the middle of the 2025. Still the fulfillment of SDG is very far. So we should be very, very serious to address all these things. And for the fulfillment of this SDG, even the academia, professionals, and the country people all are responsible to complete all these things. So financing the health sector, I'm not going to talk much more. Role of the digital health, I'm not going to talk. And again, one more important thing is that community engagement and governance is very, very necessary. And that is strengthening local level health governance, civil society and citizen engagement, role of female community health volunteer. As we all know, those who are working in Nepal, they all know that these FCSBs, they are the backbone of the country, and this will be empowered, and this will be trained, and this will be mobilized to fulfill the sustainable development goals. Similarly, the multi-sector collaboration is necessary. Still, we are doing our best to do the multi-sectoral coordination. Again, this will be strengthened and this will be promoted. And one more important thing is that One Health approach will be better to fulfill all these things. So, policy recommendation is increase public investment in health. And number two, strengthen provincial and local accountability, promote digital health and research, and build climate resilient health infrastructure. And we all know that we are suffering from so many pandemic and so many natural disasters. So we should be very, very careful on that thing also. So, and in the conclusion, just I want to say that reimagining health as the foundation of sustainable development, prioritizing investment in people, resilient health system, strategic partnership, and fostering global local collaboration to accelerate SDG achievements. So all are sleepy, so I'm not going to talk much more. Thank you very much for providing me the time and opportunity. Thank you very much.
Thank you very much, Professor Muni, for the presentation. And I think it is reiterating some of the things which we have been talking about. I think I will hand over to Professor Satpathy now to moderate the discussions. Thank you.
So, Dr. Raji, you are in order suite, right?
Yes, Professor Muni.
Dr. Padam and Dr. Sarda Prasad Osti, they are a good friend of mine.
Yeah, okay. Yep. Okay, Muni sir, we'll catch up soon. Let's leave it to Professor Satpathy now.
Okay, since with the time is limited, so therefore means we would have loved to have a far more friendly interaction than this, but we have to quickly move now to the panel discussion. And thanks for everyone for staying back. I know all of you are busy and we got delayed by a few minutes, so apologies for that. But it's been awfully kind of you to stay, and so we shall have a quick panel discussion. So the first pair of questions are related to the theme number 1, that is universal health coverage and SDG integration. So there are 4 questions in this. I'll be asking all of them together, and I would want a joint sort of response to that, because many things are interrelated. First is, what bold structural and policy reforms are necessary to align Nepal's national health system with the universal health coverage and SDG 3 targets by 2030, especially in the context of its federal governance system? And the second is, how can Nepal balance its commitment to the SDGs with on-the-ground challenges like political transitions, fiscal constraints, and health worker shortages, while ensuring that the leave no one behind principle is meaningfully upheld? Third, what policy mechanisms can better address the double burden of communicable, non-communicable diseases in Nepal while preserving gains in RMNCH, um, reproductive, maternal, newborn and child health? And fourth question is, which specific intersectoral strategies across education, gender, environment and infrastructure can support the Nepal's in national integrated progress across health-related SDGs? So these are the first gamut of questions related to theme number 1. So anybody can start.
Okay,
Why
Dr.
don't you
Meghnad.
start, Dr. Yeah, Dr.
Sorry.
Meghnad, please start.
Yeah.
You're on mute. You have to
Sorry, I was in another call, just joined. Can you just repeat the questions so I can answer?
Oh, sorry. Okay, there are 4 questions. This is theme number 1. The theme number 1 is related to universal and SDG integration. First question is, what bold structural and policy reforms are necessary to align Nepal's national health system with the UHC and SDG 3 targets by 2030, especially in the context of this federal governance system? Second is, how can Nepal balance its commitment to the SDGs with on-the-ground challenges like political transitions, fiscal constraints, health worker shortages, while ensuring that leave no one behind principle is meaningfully upheld? Third is, what policy mechanism can better address the double burden of communicable and non-communicable disease in Nepal, and while preserving the gains in RMNCH? And fourth is, which specific intersectoral strategies across education, gender, environment, infrastructure can support the Nepal's integrated progress across the health-related SDGs? These are the 4 questions.
Thank you so much. There are the many questions and some are beyond my expertise. I need to acknowledge that. Just to summarize, right, actually our national planning commissions coordinate for all the ministries, because if there are the more than 2 ministries engaged on that activities, usually it is coordinated by the national planning commissions. So national planning commission is the nodal agency to track the progress of all the SDG, to coordinate so they work. And second, as you are now practicing the federal system, so most of these SDG are like, for the federal government. But now we are also going beyond the federal government, like the provincial government, local government, and we are also tracking the progress at the federal and the local government. And third one is that there are the certain issues which are very cross-sector, like gender, right? We have the gender code for the budgeting in the Ministry of Finance, and also like nutrition management presented. So we have a multi-sector NCD action plan, multi-sector nutrition action plan, right? And these all are the coded by, again, by the national planning commissions. So bringing all the sector together and having the multi-sector action costed plan, like for climate, and also we have a national adaptation plan, health sector national adaptation plan. So we work together and we track the progress and after identify the gap. So that is a general answer. I know it is not a specific answer, but that is the current situation. Thank you.
Okay, thank you, Dr. Meghnad. Anybody else who would like to respond to these questions?
Yeah, can I respond to this question? I think, as you said, like there is valid question. There are 4 different questions. But combining that together, I think there are 3 important points that we can consider that would possibly sort of like support in whatever addressing what we want to do. The first one for that will be like understanding about evidence-informed policy making. So if we are trying to do the policy making which is evidence informed, then that will basically address many of the issues, because whatever we are trying to produce will be based on the evidence, and it will be backed by the evidence. That means that the outcome, what will be released, that will be much more effective. The second will be community engagement. And I know we have talked a lot about community engagement, but it is high time that we think about the co-production and bringing in the community at the center of the service, service not only delivery, but in the service of sort of like needs, understanding the needs, and then preparing what they are looking for it. So that is very, very important. So service user at the center of policy making and service delivery. That will be another thing. The third is more understanding between the different level of healthcare systems, whether be it at the first tier, second tier, third tier. So more understanding between those systems, as well as more collaborative approach, without the interference of political identities or political source of whoever are the political identities there, without their interference, because we know that politically, regardless of whichever party or policy it is, it will end up in 2, 3, 4, 5 years maximum. That is the lifetime of it. But we are talking about some of the health issues which will go beyond those 2, 3, 5 years. So trying to keep the health entity independent from politics will really solve a lot of issues, what we have seen on the ground.
Okay. Anyone else who would like to pick on this? Okay. If nobody is speaking on this, so let me quickly move to the next theme. Okay. The next theme is on decentralization, governance, and resilient institutions. So, Nepal's federal health system reform is still evolving. What structural, fiscal, and institutional adjustments are needed to ensure that decentralization translates to health equity and service quality across provinces? Given Nepal's federal structure, how can provincial and local governments be empowered with adequate technical, financial, and policy autonomy to lead transformative health actions at the community level? This is question number one. Second, what governance models can ensure transparency, accountability, and citizen participation in health planning and resource allocation, particularly in underserved mountain and rural regions? And the third question is, how can Nepal institutionalize resilience and adaptive capacity into its health system to better withstand political shocks, natural disasters, and future pandemics?
Okay, let me answer. Meghna sir is here. Yeah, see, actually, in Nepal, there is no concept of decentralization now because we have federalism. So federalism and decentralization is different, I think, okay? So we already have federalization with equal power of local, provincial, and the federal government. There is no central and decentralization concept. First, let me clear it after the new constitution, Nepal. Another thing was, Nepal, we have
I
excellent,
did mention Nepal as a federal structure.
No. Okay,
I
so in
did
Nepal,
mention.
let me talk about Nepal discussion. That's why I'm talking about Nepal. Okay. So
Yeah,
another one is, So another one is, see, the issue is, yes, in context of Nepal, see, centralized system or decentralized system, definitely we have federalization. That's why there is equal power of local government, provincial government, and federal government, as well as we have intergovernmental, policy framework. Okay. This is another important point. Another one is, as per constitution, as per policies, it's excellent in Nepal. But only thing is the gap of implementation. Implementation gap in terms of political stability and in terms of brain drain. There is another issue, brain drain. Everyone is blaming the country and leaving the country and giving expert opinion from abroad. So this is the best, one of the important problem was everyone love to go to America and or other developed countries and wants to have settled life, and everyone tells that Nepal is bad. This is the issue actually. So this is all about the mindset. First we have to retain ourselves in the country, then definitely we can change, because there is gap of implementation. That's why I'm talking about human resource, the mind, how we can let's say transform the mind of our future healthcare professionals and other citizens. So I think based on my some intuition, I gave this answer, and there are other experts, Professor Uma, Meghna sir, Dr. Rajiv, and others, so they will add to me. Thank you.
Others may please contribute. Thank you. Dr. Rajiv, Dr. Meghnath, and Professor Muniraj, if you want to say something.
Yeah. Okay, I will come in there just very, very quickly. I'll try to answer that. I mean, the three questions is again, I mean, very, very important questions. But I think I'll pick up on the second one, which is about transparency and accountability. And I believe that second question is, if we can sort that out, then the first and the third questions will be answered automatically. If we have got transparency and accountability in the sort of like how the health services are working, then of course that can be fixed in a more effective way. In terms of like sort of like how we can do that, or saying like how we can have a knowledge mobilization. Healthcare workforce, of course, I mean, we know that there is a lot of issues around brain drain of individuals or healthcare worker going from low and middle income country to the high income country. And I believe in the globalized world, it is very challenging to stop that movement of people from one part of the world to another part of the world. But I think, as the previous panelist, I think previous discussions, he talked about how we can make it more circular. I think that is where I'll put my money on, and I will be like, yes, that's fine if someone is in other countries, but how we can do the knowledge mobilization that can support in capacity building to deliver for the country from where most of these individuals who are abroad they believe in. And I know we have got in the panel member here who knows that there are a lot of work going on bringing those individuals who are on the other parts of the world, to bring them at the core of understanding the need of the local population and working with the local community to deliver for the local community. And again, I mean, to summarize this, it's more about not about who is where, it's about like how we can bring that knowledge together and engage with the local community to deliver for them. That is what is required.
Definitely, definitely. I completely agree. Okay, in case anybody wants to, Nirmal, you have just joined, so maybe, yes, Dr. Uma?
I want few
Yes,
points
yes.
in it. As I already mentioned, all the things, but in my opinion, lack of opportunity in rural areas, especially in a high mountain areas, high hilly areas, and hilly areas. These are the non-motivating factor for the health personnel also, and the supply chain is very difficult in certain periods of time, and also the policy implementation flaw is also there. So it really demotivating the person. And another thing is, as we are talking about the knowledge mobilization, but our system is so reluctant for giving opportunity in knowledge mobilization opportunity. So that is also one of the bigger obstacle, and poor infrastructure is also the demotivating factor for adopting all these positive interventions.
Definitely, definitely. Thank you. Thank you for such brilliant inputs. I'll go now quickly to the theme number 3, which is on climate health nexus and planetary health. There are 3 questions again. First question, what innovations in health system design can allow the Nepal to simultaneously address public health vulnerabilities and the growing threats posed by the climate change, biodiversity loss, and air pollution? Question number 2, in what ways can Nepal operationalize a planetary health framework within its national health plans to address the unique climate sensitivities of the Himalayan region and its impact on human health? Given Nepal's vulnerability to climate-related health risks and disasters, how can the health system build greater climate resilience while advancing the SDG health targets? And third question, how can transboundary environmental and climate challenges in the Hindu Kush Himalaya region be addressed through regional health diplomacy and early warning health systems?
Okay, let me try to answer this question, very vague questions. So let me start from the last one, like the climate change, air pollution, these all are the transboundary issues, right? A single country cannot answer all these problems. So we need a regional collaboration, global collaboration. That's why every year there is a conference of parties. So all the country make alliance, like some country of the mountain country. Recently Nepal organized the Sagarmatha Samvat. The aim is to unite all the mountainous country. right? And similarly, small island developing state have also their own airlines. So these are the initiative. And for the like addressing the air pollution problem in the Hindu Kush Himalaya region, we have a Mali declarations. So all the member country of South Asia unite together, and also there is a SARC, and SARC has also common agenda to address the environmental problems like the climate change, air pollution. So there are several initiatives to address the issue of regional problem like the air pollution, climate change, and also disaster. Second question is like more about the national initiative for developing a climate resilient health systems. So Nepal is one of the first country in South Asia to develop the Health National Adaptation Plan. And SNAP is also a part of building a climate resilient health systems. And Nepal has already upgraded these new one, and both plan was developed from me. I was a team leader, and to develop such a plan also we do the climate and health vulnerability and adaptation assessment, and this we need to do periodically every 5 years, because the vulnerability is a very dynamic thing, right? We have done that. So currently we are working to develop resilient health systems, which is nothing new. It's based on the 6 building blocks of health systems, which is elaborated to the 10 components. For example, normally we say leadership and government, right? But in the climate context, we have to say climate transformative leadership and governance, right? Similarly, there's a health workforce, but we need to develop the climate smart health workforce, right? Similarly, sustainable climate and health financing. And for service delivery also, we need to have a climate informed service program and others. So they are elaboration, right? And beside that, health sector is also emitter of the greenhouse gases. Like we have done inventory, we show that 4.1% of national emission is also from health sector. Now we are working how to develop a decarbonized health system, right? For that also you are working. So these are the initiative in case of Nepal and also other country of South Asia. Thank you.
Okay. Anyone else who would like to respond to this? Nirmal? No? Okay. Let's go to the theme number 4, regional cooperation and One South Asia vision. What practical mechanisms can be created to foster knowledge sharing, technology transfer, and joint health surveillance across South Asian countries to tackle regional health risk collaboratively? Question number 2. How can Nepal take a leadership role in advancing the regional solidarity and public health diplomacy to build a shared South Asian health security framework aligned with the One South Asia, One World agenda? And question number 3. Can regional cooperation help address cross-border migration and health access issues for marginalized groups in Nepal and its neighbors? What examples exist to learn from? Nirmal, would you like to start?
I will address this cross-border migration issues. Yeah, actually, if we talk about the migration issues in the South Asia perspective, then we can say that all the South Asian countries are the sending countries, that is original country for the migrations. So we also have like we also share the border with India. So we also have the main issue of the cross-border migrations and also the migration-related health issues. For example, at the time of COVID, there are many people who are crossing the borders without any visa or any proper surveillance. So we found the many cases of the COVID that is transmitted from one country to another. That was at the time that there was a big issue that has arisen. So we can also say that the South Asian SRAC is not functionally well. Even the headquarters is in Kathmandu. So we can say that Nepal can leading role to accelerate the South Asia as a regional cooperation process. For example, the South Asia is not standing there; they are not meeting for many years. So even though we have an issue of the migrations and human trafficking and other smuggling issues related to the cross border, for example, we are also taking we are also having the Rohingya refugee from Bangladesh. They are crossing to the Nepal through the India airlines. And there is also the issue related to the health of the Rohingya people, even in Nepal. So there are many areas of cooperation, and if we see the current tension between the Pakistan and India, and we can see that the Nepal is can the a very vital role not only in these peace negotiations, but also we can if we can work if Nepal can do the leading role to address this cross-cutting migration, human trafficking. As I mentioned before, that there is also the issue of the organ trafficking mostly between Nepal and Indian context. Then we can say that Nepal can play a very vital role, as Nepal is being accepted by many of this regional Southeastern regional network countries. So I think that not only we can play the very leading role for the migration and the migration related health issue, because we also have the many, like if we talk about the Nepal and Indian continent, and even in the Bangladesh and other South Asian country, we also have the very traditional this medicinal Ayurvedic medical practices that we can also collaborate between the countries. And yeah, I think that as a chair, Nepal can help to accelerate this regional cooperation process. Yeah.
Okay, thank you, Nirmal. Dr. Rajiv, do you want to say something?
Yeah, I'll pick on the first question, which was about knowledge exchange and mobilization. And as I've said earlier, about like that is very, very important. And it's not only about South and South collaboration among the South Asian regions, but also there is quite a big diasporic communities from the South Asian region who have got that knowledge that can be mobilized for the betterment of the local region. And I think, I mean, the platform like this, where you are trying to bring in that knowledge exchange and collaboration together, I think there needs to be multi-partners, and these things needs to go beyond only sorts of like webinars and more sorts of like implementation stage, where the capacity building and knowledge mobilization will, I believe, let us understand like what the issues is, and then based on that we can look for what the solutions are. So yeah, I think, I mean, moving forward, I believe the future is, because we are living in the world where it is all sorts of like digitalized world. No one is living far from one another. We all are living in a sort of like same environment, in a way where we are very close to each other, never than before, I think. And it's more about like how we can take that collective approach to do some of the things that can be beneficial for the South Asian region together.
Yes. In case nobody else wants to have anything to add to, then we can go to the next theme, which is on human resources, education and system leadership, attached to what we have been discussing. Hopefully this will give you more opportunity to respond to a few more questions. So there are 4 questions in this block. What structural investments are needed to improve the distribution, retention and motivation of health workers, especially women and frontline workers in Nepal's rural and mountainous regions? How can Nepal reform its medical, public health and nursing education systems to produce next generation leaders who are not just clinicians, but also health system stewards and SDG champions? And third question, what role can interprofessional education, community engagement, and value-based leadership play in transforming the health workers towards equity and sustainability? And the fourth is, how can intersectoral partnerships between academia, civil society, and local government create a stronger foundation for evidence-informed policy and SDG localization in Nepal? I would request Dr. Rajiv to start, then Dr. Koirala, and then Dr. Meghnath, if he wants to add, then Dr. Surya.
Yeah, thank you very much, Professor Satpathy. Again, I mean, this is quite a lot of question, and I believe the educational system, as Dr. Surya highlighted, the reform required also like at least an overview of how we can understand the educational system in a better that can support the needs of the local community. That is required. But I think more than that, I also need to think about like why sort of like the health workforce is diminishing day by day and why we are not able to retain that. And I think that is where the question number 4 about like intersectoral partnership comes into play. And it's more about like not only about the producing the doctors and nurses and how we can sort of like bring in those private sector investment in a more equitable way so that we can provide the health workforce that needed support that can sustain within the country itself, and that will be the way forward going that. And possibly also relating to that, I think the question was about evidence-based informed policy making. I think one of the, to my understanding and as far as I know from the reading, is like one of the reasons why the health workforce is leaving Nepal is not always about money. It's also about the dissatisfaction in the working environment, and I think that can be improved through the evidence-informed policy making, strengthening the worker rights in terms of like medical settings, and I think that can be the approach that can be taken, which can ensure that the policy is there to protect the health service user as well as the health service provider and the workforce which is providing that services. Thank you.
Sweet. Thank you. Dr. Uma?
Uh, Actually, last question you have explored about the local government, community, academia's co-work and how it can be strengthened. In my experiences, we in Nepal, as also Bangladesh colleague also expressed the same thing. We work in a silo. There is no coordination between local government, community, and academia. Even academia, we think it is a different entity in the world of Nepal. So there is no linkage between community and academia and local governments. Uh, there is no connection, absolutely no connection with the community. The knowledge sharing process, coordination process is nothing over there. So that is the biggest flaw in our policy. We have a very wonderful policies as we all regard for this, but the implication part and the government's investment in education sector is a very huge, lavish investment is going on. But what is the trust and what is the fruitfulness of those investment if the community people are so aloof and they are not getting any benefit from those investment? So these are the big issues, and maybe policymaker and political leadership will think very seriously about this issue.
Maheswar, can I add some?
Yes, please go ahead. Please go ahead.
From the civil society perspective, then we have practices many things. For example, the community mobilizations for our community mobile clinics. So we have been conducting mobile legal clinics in different ways. So from their perspective, then we are getting the first-hand informations, and we are easing the problem of the communities to bring so policy. So that is helping to the process to collaborate with the civil society. Mostly we work with the local governments. So we are also sharing the message from the local, national to international to the local in the localization process, and we are also getting the local informations to the national and provincial level. So we are trying to engage the academia, also the professionals in our practices and in our many discussions. That the civil society organizations can work to interconnect between the different stakeholders, including academia, government, and policy makers. So I think we can coordinate on that part, and we are doing. We have many examples that we can share.
Yes, I'm going to ask two more questions which will allow every one of you to respond to few things which you are trying to speak about, but maybe think more about and respond to that. So these are, how can Nepal build people-powered health system that are rooted in trust, social accountability, and co-creation rather than the top-down delivery alone? And another associated question, what role does gender justice and feminist health systems thinking play in achieving the transformative health outcomes across Nepal?
From the I just go to the gender prospect. From the gender perspective, still the health sector is not so friendly. We can frankly say most of the marginalized population and most of the rural population has a very rare access to the health services that are providing by the health centers or health service providers. Though the government has given many facilities in their policy, 96 types of medicine are distributing free in the from every health facilities, but there are no medicine at all. We have to buy. The people have to buy from the private medical shops instead of getting those facilities from the health service provider or health service. And another major critical things is the many marginalized communities such as Muslim women and LGBTQ community and very marginalized, as we are familiar that Dalit groups, they are far behind those facilities and they are very gendered in these situations. Yeah.
Definitely. I had a question related to that, but I didn't ask because of lack of time. But it's fine. Thank you. You covered it. Thank
So,
you for that. Yes, you want to
Maheswar,
say?
I will just
Yeah,
add.
Ned.
I will just add
Yeah.
one thing, that how can we make the top to down or bottom to top approach, and how can we connect with the people, and how can we gain the trust of the people? So one thing we can do is that the most important thing is the information flow. No, so in many examples we have in the many issues that I have particularly experienced that people, like for example, in my presentation, I talk about that 96 kinds of medicines are available, but most of the people, they don't have idea that that is available for them. And second thing is that people don't ask the questions to the authority. We can make authority accountable if we start asking why the medicine is not available on that places. Then they will start, they need to start, or they will start responding the things. So we have to work to bring the trust of the people, that first the right information, second we need to make accountable to the service provider through the beneficiaries angles. That's it.
Definitely. Agree. Completely. Yes, Dr. Rajiv, do you want to say something?
No, I think, it has been said, but I will just relate to one word which you said, like co-creation. I think that is the future. That's all I'll say. It's more about community engagement. It's not about top-down anymore, and we all know that. Even the service user knows that. I completely agree with Advocate Nirmal, what he said about, like, we don't question the authority, but we need to change that mindset and we need to work towards it. And with the information flow that is happening now around the world, I think, yeah, we are moving towards that positive insight, and it will take some time. We cannot change everything overnight, but more and more questions are being asked. But I think it's more about, like, changing the sort of, like, the institutional culture that will help, and that will start from how we can create something, how we can co-create something. So let's say if there are some services, then if the participants or the service user are involved with the production of that services, then they automatically become accountable for that and they become responsible for that. And that is the culture we need to start creating. The more we create such a form of culture, the accountability and the sort of like responsibility will come within that community themselves. And that is very, very important part of what we were talking about earlier, that the local government has got the power now. So if the local government has got the power, they need to practice that power to the maximum extent in the collaboration with the community whom they are serving for. And the day we change that culture and the day we understand the importance of that, I think we'll be a winner and we'll be able to move forward with a better healthcare services.
Okay, wonderful. In case anybody wants to contribute, you can. Otherwise, we'll move to the last two questions quickly. Anybody? Dr. Surya, Dr. Meghna? No? Okay, great. So I go to the last two questions. These are very important questions, so I would request everyone to respond to these two questions. So if we imagine Nepal's health system in 2030, what transformative milestones must be achieved in the next 5 years to ensure that the SDG health goals become a reality, not a promise, deferred? And question number two, how do we move from fragmented projects to integrated, lifelong, and sustainable health systems that reflect the spirit of one South Asia and one world?
Okay, let me add one. Okay, so if it is possible, what I expect, 100% 100% health literacy in Nepal. If 100% people will be health literate, definitely we can solve the problem. And another one is health system engineering. Okay, so see, we need to have reform. Okay, in the health structures, governance. Let's say all the health WHO health system blocks, 6 building blocks of the WHO. Now we have everything in Nepal, especially in Nepal. Okay, policy, uh, programs. Okay, even budget, human resource. But the problem is that we have no interdisciplinary approach. We have somehow multidisciplinary approach. But the problem is interdisciplinary approach, interconnected niche. Another one is not only the health. So we have these issues in other sectors as well. Okay, so that's why if we want to retain, if we want to improve the health system by 2030, we need to consider other sectors as well, service sector, okay, business, there are other sectors, I mean to say. So we need to, think about none beyond the health sectors. So if we consider beyond the health sector with the traditional health sector, definitely we can have a better transformed health system in Nepal in the year 2013. So let's hope for best transformed health system in Nepal. Thank you. Another one, Dr. Rajiv will answer.
Okay, let Dr. Meghnad come first because he was saying that he has to go. Dr. Meghnad, if you are listening to us, please respond to these two questions. We'd love to have your views.
Sorry, I don't have also the new answer, the similar answer, but just want to highlight that every time we blame, we have a fragmented health system, we don't have the good, let's say, health workforce. But I'm optimistic. What we are doing is great. Let's just take the lesson from the COVID-19. We taught the health system of UK, but the mortality of much higher in the UK, Norway, even Italy, US than Nepal, right? So whatever we have indigenous knowledge, existing system, we definitely need to strengthen, but we cannot make a radical change. So our strength is our indigenous knowledge, right? And we have to make a decolonize the global health. Whatever is the strength from our side, from let's say global south, I think we need to take that strength, right? If you just for example, let's say food security example, we have so many very good food, but what we promoted is that imported food. That's all the people are now dependent on this external food. there is no any probability of sustainability, right? So means whatever we have now, I think it is not sufficient definitely, but we need to strengthen rather than just inventing the totally new. And next important point is that we need to generate the local data, local evidence, and that evidence should be incorporated into the policy and planning. So what is missing currently in the in case of Nepal is that most of the research are focused to the national level, let's say federal level, and when the people make a plan at the local level, at the municipality, they don't have the evidence. Like how much money they have to allocate, let's say, for dialysis service, or how much money they have to allocate, let's say, for the you know uh, smoking cessation program, right? Means we need at least the evidence so that that evidence can guide the evidence informed decision making, right? And next is the quality of health service as well as quality of the research. Number of research paper that is being published each year for Nepal is going very high, skyrocketing. But now equally important point is how much this research paper contribute to policy and planning, and what is the quality of this paper, right? We have to focus on that. Same goes for the health service delivery. We can increase the coverage, right? But in the same time, if they cannot improve the quality of the health service, means that doesn't improve the health status of the people. That's my just thought. Thank you.
No, definitely. Very, very pragmatic and very thoughtful remarks. Thank you, Dr. Meghna. Okay, now we'll go to Nirmal. After that, Professor Uma, and at the end, the chair. Some concluding remarks. Yeah.
Okay, thank you, Maheswar. I think that if we talk about the Nepal perspective by 2030, then I can say that we can promote the Nepal as a hub of the medicinal herbs, because Nepal is a very rich. Nepal has a very rich resources of the medicinal herbs, and we are not recognizing our strength, our medicines, and we are also forgetting our traditional medicinal practices that is also curing our diseases before, and now we are also only depending upon the like company made medicines. So we also need to promote our local resources, local techniques, local traditional hubs, and we can be the hub of the like mountainous hubs. And second is that we need to focus on the universal health coverage, and we also need to come out from the medical poverty trap that I have stated before. So that could be the milestone for 2030. Although we are not will not be the successful to achieve all the goals of SDGs by 2030, but we have some good examples that our previous speaker has also shared, that we are doing very good things in many issues. So we can take that examples, and we can relate. We keep continue this our good best practices. And second is that how can we do the integrated, because we know that we are very close in the South Asian, and our landscape, our geography, our temperature, our climate, all seems look similar. Then we have some similarity, and our students in the medical fields, our people are going to India, the students are coming from Bangladesh. So we also have a different kind of sharings between our educations, between our knowledge, between our practices, between our cultures. So we can use this all our strength in the South Asian regions to make integrated approach to help each other, and to get to be benefited from each other knowledge, experiences, and our resources that we have in the South Asia that we are lacking, and we need to initiate on that issues so that we can be the very hub the medium from the health perspective. Then we can be very the focal area in the world that we can practice. And we already have some in the, if we see the India now, we can see the many examples that even from the Middle East, that people are coming to India for the health checkup. So why can't we do for the Nepal, and also from Bangladesh, Pakistan? So we all have all the strength and resources that we can use, and we can cooperate each other to make our South Asia with the better health conditions. Yeah.
Definitely. Yes, Professor Uma.
Thank you, Professor. For 2030 agenda, in my view, health facilities should be easy access to all. The health facilities should be affordable, quality, and access to all. And all the population should be under the insurance network or insurance umbrella. And last but not the least, nutrition should be in the center of all health care. Thank you.
Okay, right. So we have the last Professor Rajiv.
Yeah, no, thank you very much, and thank you very much for allowing me to put the concluding remark here. First of all, yeah, thank you everyone, all the panel members for your contribution and all the sorts of like lively discussions. Just to sum up, I think we don't have a choice now. I think the agenda of global collaboration and regional collaboration is very, very important. We know that we are doing global collaboration, but in the current times, that global collaboration is looking somewhat scratchy at the moment, and you can see that the funding, especially the aid funding from all the developed countries, has decreased so much that we don't have an option without sort of like going for the regional collaboration. That is the only way to succeed within South Asian region now, because we have got, I mean, as you know, that the most of the funding has dried out from America and from UK and from many of the Scandinavian country. So I think in terms of like the intellectual and in terms of like the other side, the other country can take the lead. But in terms of like the economic side, I think India has to take the lead. There is no alternative to that, because that is the way the regional collaboration will work, and that is the way we can ensure that we are surviving and thriving together rather than in a fragmented way. And what does that mean is like not doing a fragmented research which is based on just one locality or one source of like country, one district. It's more about like how we can do the research that bring the collaboration of all these sorts of like the SAARC countries, the 8 countries. I'm saying 7, 8 because we know what is the issues with some of the countries not coming together. So at least let's say majority of the South Asian countries coming together for the research project and understanding from each other will be a way forward, and that will give us a practical and sort of like transformational agenda for 2030. For me, the transformational agenda for 2030 will be like how we can succeed in that regional collaboration. That will be what I want to see. Thank you.
Excellent. I think we couldn't have had a better closing to this entire panel and the entire session today. It's been more than 5 hours. Our participants have been here with us. It's 11 p.m. Indian Standard Time. Still 146 people on the call. And that shows the level of engagement, the commitment, and the true and authentic interest in the causes that we are working for. So we started with around 200 plus people, it went up to 300, and then it went and grew in between as the panel shifted, and we still had up to 278 just a few minutes back. Now it is 150. So that just shows the level of engagement. So I'm profoundly indebted to all of you, Professor Rajiv Kumar Saab, Professor Uma Koirala, Professor Muniraj Chetri, who is not here, then Dr. Meghnad Dhimal, and Professor Mahesh, Dr. Mahesh, who came and stayed with us for the entire duration but could not attend the panel, and then Dr. Prabhat Kanal and Nirmal Kumar Uprati, my dearest friend for the past 20 years. It's a wonderful opportunity that I'm meeting him in a panel and I'm seeing his child on a live call, and I was thinking for the entire time, how is he managing like both the things together? Means I'm not married, so I don't have to really worry so much about these things, but how is he managing? That's what actually was going on in my head. I think it's quite a challenge on its own, but I think it also gives you opportunity to do multitasking in a different way. I do multitasking as well, but I think this is a different level of multitasking. And look at the level of interest of that child also, that sees very patiently. I have not seen children literally putting the earphones in the head and ears and listening to these lectures, and she is giving attention, she is paying attention, which is very interesting. So, wonderful panel, wonderful ideas, excellent ideas. I think we have come to the consensus, as Dr. Rajiv just poetically put, that we do not have a choice. We have to come together, we have to work together, and we have to co-create. That is the future. And if we can do it together without being, disintegrated, and if we can become an integrated whole, then probably there will be better future together. And the future is always together. There is a very famous saying which goes into community building, because Nirmal and I both work with communities of different kind. So we always say, together we are better. So, so I think that's the sentence with which I would also like to end our session with. So I would like to inform all of you panelists that thank you for coming on the board of Global Consortium of Global Health. I, on the behalf of Global Consortium of Global Health, Actors, Leaders and Thinkers, Global Health Forum, Global Brain and Mental Health Forum, World AIDS Forum, and Bangladesh Institute of Innovative Health Research, would like to place on record my sincerest and most profound gratitude to all of you for coming on a Sunday evening and spending the entire evening with us. It's very late in Nepal, I know. So you have been here with us for the past 5 hours, which shows the level of commitment that you have and the level of genuine interest in shaping the healthcare policies and actions and the collective future that we have to redesign and reimagine together. And that's the only way forward. So I place on record my sincerest and most heartfelt gratitude. And I would like to inform you that our Global Advanced Certification Program participants will receive 2 certifications. One is a certificate of completion. Another is a statement of higher education achievement, which will bear the signatures of all the resource persons who have come so far and will be coming in future, and they'll receive that document. This is a document that is given in the pattern of UK and Australian higher education patterns. And this, so far we have had professors from top universities, Yale and many other top universities, and very soon we'll be having professors from many other top universities coming through. And we'll have joint panels happening next week again. That will be the India Forum. So India Forum is going to be a full evening national panel, national symposium, rather than in place of a panel, it will be a full national symposium. So I again invite formally to all of you to please join if you have time next Sunday. Please book it in your diaries. Many eminent people, top scientists, as well as ministry officials will be in attendance. So we are very, very busy right now planning that and organizing it. And we are extremely indebted to all of you for your presence and sharing all the wisdom and experience, especially to Dr. Meghnad, who is a little irritated with me, but he has been very patient with me. For the past 5 years, he has stayed and he has attended. Dr. Meghnad, if you are here and listening to us, I would like you to please come on camera so that we can take a screenshot of your presence. And it's been a wonderful experience hosting you. It's been wonderful experience talking to you, getting to know about all the perspectives, what all thoughts go on in the national health policy planning and implementation, which is the most important part. So the future obviously belongs to those who are optimistic and pragmatic. So you are optimistic and pragmatic. Obviously, that makes you a leader in true sense. And so, yes, I'm very, very indebted and grateful to all of you. And I couldn't have been happier because today's sessions have been really great. I've been very, very happy about the kind of response and the engagement of all the participants and all of you. And what we are planning moving forward, we are planning to come up with an issue. We'll come up with 2 things. First is a policy document, which will be submitted via you to your own national governments. Second thing is we are also planning to come up with some academic papers on the basis of these panels. So that will be communicating you regarding that. And as far as your signatures are concerned, the admin team will be getting in touch with you. So please cooperate and oblige us, and that will be placed on the certificates of participants. So thank you so much. That's all from my side. It's been wonderful. I would love to work with you in future. We'll build the global consortium of global health together, because this is the largest global consortium in the world today, led by people based in Global South. We have more than 2,000 members with full documentation. So we have proof to prove that yes, we have members. So that's all from my side, and the rest of the thing will be done by Faisal. Thank you.
Thank you, sir. Thank you for providing
Thank you, everyone.
us the opportunity. Thank you. Good night.
Bye.
So we thank our brilliant expert panelists from Bangladesh and Nepal for today's deeply thoughtful and visionary contributions. From national perspectives to regional challenges and actionable policy shifts, today's discussions re-emphasized the importance of resilient, equity-driven health systems in South Asia. To all our participants, thank you for your active presence. Let us continue to learn, lead, and collaborate to build a healthier, just, resilient, and sustainable world. We look forward to seeing you all in our next session of the GSCP's SRCCER series. Until then, stay safe, stay inspired, and have a good night. Thank you.
Thank you. Thank you.
Thank you. Thank you so much. Please take care of yourself, and I'll see you.
Thank you.
Okay, thank you.
Okay, thank you, Dr. Surya, for staying on board. It's been wonderful. Take care. I'll see you soon. Yeah. Okay. Right. Okay, participants, attendance link has been posted in the chat. Please fill it up and fill it up correctly. Please fill it up with your correct email ID so that you receive your certificate. Please don't bombard me with n number of requests of certification, because we are actually very, very busy. Okay, to organize these events. Okay, so please bear with us. We'll all get your certificate.